generó un board de excelencia y trabaja en el Instituto de Biomedicina en Sevilla, en el IBIS. Es vicepresidente del Grupo Español de Investigación en Sarcomas y además es líder de CELNET, que es un puente y un vehículo realmente increíble entre lo que es Europa y Latinoamérica. Así que realmente para nosotros es un privilegio, pero enorme, que nuestros residentes o nuestros médicos en formación te escuchen. Probablemente esta vía y la pandemia nos haya permitido esto, pero realmente para nosotros es un privilegio. Así que, Javier, te escuchamos en lo que es tratamiento perioperatorio de los sarcomas de partes blandas, así que te volvemos a agradecer. Muchas gracias.
Muchísimas gracias, Matías. Es un placer para mí estar en esta reunión. So I will speak in English because my colleagues, the partners of this talk will be, I think the English will be the vehicle most appropriate for understanding all together. So thank you, Matthias and his team for this kind invitation. It's my real pleasure to be here and to be participant of this course organized by Association of Clinical Oncology from Argentina. So my topic is preoperative chemotherapy or chemoradiation therapy in soft tissue sarcoma. And I will try to explain that in the next 20 minutes, giving some time for interactions or for questions at your convenience. So the general rules of perioperative chemotherapy in soft tissue sarcoma, we have to say that it still is a controversial issue. According to meta-analysis in LIMS, where is more years more prescribed, there was a 7% of absolute benefit in terms of overall survival. This is somewhat that in other solid tumors is adequate as well for perioperative adjuvant or neoadjuvant chemotherapy. But it's true that we need an adequate selection of patients who are the most high-risk population, the most subset of patients that could be benefited by this perioperative chemotherapy. And obviously, what is the best full dose scheme that we can recommend currently. So we have to know that there is some prognostic studies saying that there are factors that with relevant in prognosis as the grade. The grade is something that pathologist is providing us and is built with three different aspects. What is the differentiation of pleomorphism of this tumor? What is the extent of necrosis in terms of percentage? And what is the mitotic count? These three factors are relevant for this grade. The final grade will be built following the French system. And this is obviously the most important prognostic factor in localized disease. The second most important is tumor size. The 5 centimeters or 10 centimeters are the cutoff usually used in these prognostic factors. And the third most important is tumor depth. If it's superficial or is the tumor is located deep with respect the superficial muscle fascial. Okay, these are the three most important factors that can have relevant influence in prognosis in localized disease. But as you know, there are many different subtypes of sarcoma, of soft tissue sarcoma, and there are more than 70 subtypes, and not all the subtypes are have the same behavior in front of chemotherapy or in front of localized disease after a good and adequate surgery. For instance, malignant peripheral nerve tumor have literally less influence in the prognostic factors as grade, for instance. When we apply the grade according to French system to malignant peripheral nerve tumor in localized disease in limbs, for instance, the impact in overall survival is clearly different than other most frequent soft tissue sarcoma. And also in UPS, or excuse me, in unclassified sarcoma, NOS, those tumors that the pathologist said, this is clearly a sarcoma, this is clearly a mesenchymal tumor, but we cannot fit this case into the different, already know histology subtype. So this should be taken into account as well, because not all the subtypes are behaving in the same way, and not all the prognostic factors are impacting in the same way in these different subtypes. And also important is that the impact of adjuvant chemotherapy, according to this relevant study from French colleagues, when the tumor is classified as grade 2, those patients carrying these grade 2 tumors have no benefit with perioperative chemotherapy. But those with grade 3 did benefit with perioperative chemotherapy. So it's not the same grade 2 than grade 3. Even when we are considering high grade, both grade 2 and grade 3. But in the end of the day, grade 3 clearly is more appropriate for chemotherapy in terms of perioperative chemotherapy in those soft tissue sarcoma, especially in limbs. So just taking a glance, those studies, those randomized trials, comparing control arm, that means only surgery, versus chemotherapy, perioperative chemotherapy. Most of these studies, chemotherapy was given in the post-surgery time, so as a adjuvant setting. So in these first generation trials with doxorubicin, as you can see in the screen, there are few patients, very few patients. Most of them, excuse me. My voice. As you can see, the most important trial, this Scandinavian trial, only 77 patients in each arm. But for most of them, there was no significant difference in favor of chemotherapy. And you can see it's normal because the number of patients is quite low. It's true. And the first generation trial about polychemotherapy with different schemes in that time, these are trials designed in the 80s, in this decade, in the 80s. So in that time, polychemotherapy was prescribed following or mimicking other tumors as non-Hodgkin lymphoma or as germ cell tumors, where polychemotherapy was clearly relevant to make more cure rate. So, but in sarcoma, the combination of 4 drugs, as the FIBADIC scheme, for instance, did not demonstrate survival benefit. So, as in the monochemotherapy, in polychemotherapy was the same history. Relatively low patients if we are not considering the ERTC trial, but without a significant difference in most of them. So for overcome these limitations of these studies, meta-analysis were put on the table. And this was the most important meta-analysis because this meta-analysis took into account the individual data of the patients. So what we can say is that there was no significant difference if in overall survival, only 4% of absolute benefit favoring the chemotherapy arm. But we have to take into account that these first generation trials did not consider an adequate selection because all the locations were included in these trials. I mean, those patients with retroperitoneal sarcomas, and those patients with head and neck sarcomas, those patients with visceral sarcomas were included in these trials, in these first generation trials, in just focusing on the value of chemotherapy in the perioperative setting. So despite that, in limbs, there was a 7% of benefit, which was significant, the difference, in limbs favoring the chemotherapy arm. So this is the most important meta-analysis, trying to overcome the limitations of the small studies in soft tissue sarcoma, in localized soft tissue sarcoma. But we have to take into account these limitations of not an adequate selection of high-risk patients, and also not an adequate drug selection. And actually, in these first-generation trials, only 3% of patients had received ifosfamide, which was considered the second most active drug following the doxorubicin. And also, these schemes had a very low dose intensity for anthracyclines. So these first generation trials had several critics, and nobody believed in this effort, which was huge effort in the 70s first, and then in the 80s years. So the second generation trials had another different focus. Okay, what are the most important or the most active drugs in soft tissue sarcoma? Anthracyclines and ifosfamide. Then let's combine these two drugs at the highest possible dose intensity, and then we have to check that in localized disease. And not only that, but in some trials, there was a very good selection of high-risk population. For instance, in the Italy trial, only those patients with grade 3, only those patients larger than 5 centimeters, and only those patients with tumors larger than deep located were included in this kind of studies. So these second generation trials focus on a better chemotherapy scheme at a higher dose intensity for those patients, for those drugs, more active drugs as doxorubicin or epidoxorubicin plus ifosfamide, and also an adequate patient selection considering just high-risk localized disease. And in addition, not all the histologic subtypes were enrolled in these trials. For instance, in this Frustaci, in this Italy trial, there was also a selection of the histologies trying to mitigate the bias included by heterogeneity, because if you are including in these trials, for instance, the differentiated liposarcoma of the extremities is not very frequent, but this is a possibility. Then you are entering heterogeneity, and it's more difficult to make conclusions, at least robust conclusions, with regard the role of chemotherapy in perioperative setting in localized soft tissue sarcoma, and also importantly, to select just patients with the same biologically behavior. I mean, those soft tissue sarcoma stemming from limbs or trunk wall, in the end are behaving similarly and very differently than retroperitoneal space or head and neck tumors. So this was also important, because you have to make a big effort to make a homogeneous population for these trials. So for us, the Italy trial was the innovative, because an adequate selection, and also because the highest dose intensity for the two most active drugs in soft tissue sarcoma. And the next meta-analysis, unfortunately, was built without individual data. So this was an example, and this second meta-analysis took into account those trials, including ifosfamide as a perioperative drug in localized soft tissue sarcoma. And for this meta-analysis, especially the combination of anthracyclines plus ifosfamide had significant differences in terms of distant recurrence, in terms of overall recurrence, or in terms of overall survival. And then the critics for this meta-analysis is that was not built with individual data. Okay, this is a kind of limitation, but interestingly, these patients treated with this combination had a significant benefit from this perioperative chemotherapy. As I mentioned, this scheme from Italian sarcoma group, led by Sergio Frustacci, demonstrated that the 5 cycles of epirubicin plus ifosfamide were significantly better in terms of disease-free survival and overall survival than control arm. So this was the Kaplan-Meier curves at the time of 5 years of the median of follow-up. But with increasing, but increasing the follow-up, this significance was lost. But interestingly, it was lost because 7 patients in the arm of chemotherapy did not receive in the end chemotherapy. So in the per protocol analysis, this difference still was maintained with a longer follow-up, with a follow-up of almost 8 years from surgery. So the next study conducted by Italian sarcoma group, also a Spanish sarcoma group participated in this study, wanted or aimed to compare if 3 cycles would be enough. So this was compared 3 cycles in the neoadjuvant setting versus 5 cycles in the perioperative. 3 in both arms. The first 3 cycles were administered in the preoperative setting, and in one arm, 2 additional cycles were given in the postoperative setting. So this trial gave the same results and no differences between 3 versus 5 cycles. And again, there was a selection of patients, only those patients considered high risk localized soft tissue sarcoma from limbs or trunk wall, and not all the histologies, but the 5 most frequent histologies: leiomyosarcoma, UPS, malignant peripheral nerve tumors, synovial sarcoma, and myxoid liposarcoma, hypercellular myxoid liposarcoma. So these 5 histologies were considered to be enrolled in these trials. Interestingly, with the same selection of patients and with the same scheme, obtained the same results in terms of overall survival. So I think this was an important conclusion. So the third study tried to demonstrate that some specific schemes for different histologies could be better eventually than the control arm built by epirubicin plus ifosfamide. All schemes were considered only for 3 cycles. And in the interim analysis published in Lancet Oncology, we saw that those patients treated with epirubicin plus ifosfamide had significantly better relapse-free survival and overall survival. At this time, the median of follow-up was just 1 year, so this was considered a preliminary results. So in the final publication of this year in Journal of Clinical Oncology, the mature data demonstrated that the overall survival still was significant. There was significant differences in overall survival with a median follow-up of almost 5 years, and the disease-free survival was not significantly different between the standard chemotherapy versus histotype tailored chemotherapy. So for many of us in this specific population of high risk soft tissue sarcoma, 3 cycles of epirubicin plus ifosfamide at the highest possible dose is the standard. I mean, it's not open for all the locations. It's not open for all the histologies. It's not open for all the risk patients. But for high risk localized soft tissue sarcoma with some histologies in limbs or trunk wall, for us is the standard scheme. So one question is, neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy does improve resectability? We have to take into account that 80% of soft tissue sarcoma in limbs are resectable. More or less 15% are doubtful in the gray zone, and 5% will be unresectable from the very beginning. So in this case, we have to have very clear that those 5% of unresectable tumors will not be converted to resectable after neoadjuvant chemotherapy or neoadjuvant chemoradiation therapy. It's true that in some patients within this gray zone, those with doubtful resectability could be benefited by this treatment. But this is not the first aim of this perioperative chemotherapy or neoadjuvant chemotherapy, because the first aim is a gain in overall survival. Okay, but it's true that in some cases this chemotherapy could facilitate or could make easier the surgery. This is an example of a synovial sarcoma in a young female patient. This tumor involved two compartments in the thigh, and after chemotherapy, 3 courses of chemotherapy plus radiation therapy, the surgical team is estimated resectable after this induction. But this is not the most frequent event, because the most frequent situation is that the volume of the tumor is not changed enough to consider that this shrinkage in the volume is enough to be resectable, the tumor. So this is not the first time, as I mentioned, of the chemotherapy in limbs. It's interesting. We are knowing, or we are gaining more knowledge about some radiological assessment that could anticipate a prognostic for a specific patient, and all the radiological examination we have considered in the 2 last trials with the Italian sarcoma group, maybe the diffusion index in MRI is the most important herald, is the most important prognostic factor, but we have to check, we have to validate this information. Just to share some details around that. This is a myxoid liposarcoma, high-grade myxoid liposarcoma. As you know, this high-grade myxoid liposarcoma means that more than 5% of this tumor are composed of cellularity, hypercellularity, high cellularity, maybe round cells, but not necessarily round cell, maybe spinal cell as well. But in this case, this was the largest dimension at the time of diagnosis, and this was the diffusion index estimated by MRI at the baseline. As you know, if we are gaining in diffusion, means that the tumor has more space for water molecules, and this means indirectly means somehow this tumor has changed. There has been a histological response after the chemotherapy or chemoradiation therapy, and after the first cycle, the tumor size increased a little bit, as you can see, but the diffusion index as well increased. That means there was a histologic response in this tumor. And after 3 cycles, the maximal dimension is shrunk up to 9 centimeters, and the diffusion index increased even more up to 234. So in the end, this case decreased in 21%. This means by RECIST stable disease, and the diffusion index increased at 68%. Interestingly, the pathological response was 95%. And we have seen that those patients which tumors have an increase of diffusion more than 50%, we usually see that the histological changes after the pathological report is more than 85%. So we have to check if these changes will have a final prognosis in terms of disease-free survival and in terms of overall survival. But maybe this is interestingly to know that a kind of tool that we have used in the daily clinic. We have also information that if we are discussing in the sarcoma board, in the sarcoma committee, the probability of ER1 resection in this tumor is high, then we advise for chemoradiation therapy in the neoadjuvant setting, because we have seen that if we are using radiation therapy in preoperative setting, the ER1 impact on overall survival is prevented, is diminished. So it's not important, the impact of ER1, because we know that ER1 resections have an impact in overall survival after 5 years from the surgery. Okay, but this dismal prognosis is not seen if radiation therapy is advised in the preoperative setting. So this is just to take into account that is feasible in our hands in these two protocols, the combination of epirubicin plus ifosfamide plus radiation therapy in the neoadjuvant setting. In the end, there was 44 grays administered in this time. Okay, just remarks in neoadjuvant chemotherapy. Coadjuvant chemotherapy could be advisable if localized high risks of sarcoma in limbs and trunk wall. Full doses of anthracycline ifosfamide are the recommended scheme we are using, and we think it's necessary to individualize the decision-making process with the patient, explaining the pros and cons of these schemes. And also the neoadjuvant chemotherapy is better than adjuvant chemotherapy if we can anticipate, for instance, ER1 margins. It's more valuable because we can obtain more prognosis information at the radiological and maybe molecular or maybe pathological setting. And we need to gain more knowledge in prospective clinical trials with this neoadjuvant chemotherapy, and maybe then we are discussing what will be the next study, trying to improve the 65% of overall survival in this specific population of high risk localized soft tissue sarcoma in limbs and trunk wall. Thank you very much for your attention, and we are very open to answer some questions or doubts. Thank you very much.
Gracias, Javier. Thank you, Javier, because he's Janib's at the just he's arriving at our meeting. So we continue in English. Hi, Janibs. How are you? So if you want to open your microphone, it's okay.
Sorry, everybody.
Hi.
With the microphone.
Javier, for our practice, what do you think about the new strategy to perform as neoadjuvant therapy, immunotherapy plus radiation in those patients who have locally advanced sarcoma?
Yeah, we have to know firstly what is the added value of immunotherapy to chemotherapy in advanced disease, just to perform a phase 1/2 trial before to translate that information in the localized setting. I think this is very, very interesting, very attractive, I said. But again, this is a trial we are performing with several hospitals, but we are performing the phase 1/2 trial in advanced disease. So if we detect some signal of added value, then maybe this could be translated in the neoadjuvant setting or adjuvant setting. It's true in lung cancer, for instance, there is very good results in the stage 3 in non-small lung cell cancer with the combination of chemotherapy based on platinum and nivolumab, for instance. So the percentage of complete pathological response is significant, is clearly better than historical control. And this could be an advance in lung cancer. We don't know if we will be able to make that in soft tissue sarcoma, but this is very attractive because doxorubicin, for instance, is a kind of drug that can induce those effects called immunogenic death. That means that after doxorubicin effect, these cells can be make a cytokine call and to activate adaptive immunomodulation that could be against the tumor cells. But at the time, currently we have no sufficient information for that. But it's, as I mentioned, very attractive, Matthias.
Okay. Do we have any question inside the fellows?
Oh, Matthias, there are no questions.
I guess we can incorporate Shanib's to the same question. And what do you think is related to the next future in the adjuvant setting? Do we have to collect all the patients with several histologies, or we have to individualize and get short-term clinical trials with different histology, and that's the end of to mix all the histology as we do in the past?
Yeah, I think you're absolutely right. It's what the results tell us now is that the work that we have been doing for decades, which is gathering people with different histologies, has been fruitful, and it helps to define some standard treatment. But right now we have reached the limit of that, in that we are not able anymore to progress. And probably the main reason is that we need to split these different entities, which are many, into different groups, which are even rarer and even more complicated to do a clinical trial. Of course, a randomized clinical trial, but also a clinical trial by itself. So one of the future of clinical research in sarcoma means that we are going to need to split, I think, and to unite at an international level, because we will need to gather our experience together and to do the trials together in order to solve the questions for the rare subtypes.
Javier, can we use any surrogate of overall survival in the clinical trials in an adjuvant setting, as in colon cancer or other pathologies, as disease-free survival to 3 years as a surrogate of overall survival benefit?
I think we have several prognostic factors that in some way has been validated in different retrospective series, but I think the most valuable determinant for prognosis in localized disease is the nomogram. The nomogram has been validated in 3 different series and with a large number of patients. And I think this should be taken into account for taking decisions in perioperative chemotherapy. So far, we have not molecular determinants in terms of prognosis in localized disease, unfortunately, but you know, maybe it's very difficult because we are not talking about one specific disease, but several diseases. So this is a huge challenge. But I think the nomogram so far, the nomogram is the best tool to as determinant for prognosis and should be incorporated in clinical trials, I think, and also in the daily basis or in the clinical practice.
I guess the last question for adjuvant setting, I guess if the patient can come to you with just a resection, a complete resection, how many cycles of doxorubicin you give to the patient as adjuvant therapy if the tumor is more than 5 centimeters high grade and deep related to the fascia?
If the patient has the same high risk determinants I have mentioned, in some centers, we advise for 3 cycles of doxorubicin or epirubicin plus ifosfamide, just 3 cycles. Within these conditions of some histologies, of some prognostic factors, and also within some age, because over 70 years old, we are not advising for this adjuvant chemotherapy.
Okay. Shanif, do you agree?
We do exactly the same, and we use exactly the same tool. So it's very interesting.
Okay. Well, Javier, I guess you have to go to sleep because you are on holidays. So we give all the welcome to Shanif. Shanif Zulay is the president of Unicancer, and he's the director of the General Centre of Léon Bernard Lyon, and from the French sarcoma group. So we give you all our regards, Javier, and we are very welcome with Shanif. Thank you.
Thank you very much, Matthias, and hi to Javier. I don't know you are in vacation, by the way. I'm going next week for myself.
You are very near to the midnight, Janip.
Yeah, not yet. It's close to. Let me share my screen. Here we are. So you have the slides, and I share that with you, so feel free to share them. So first, thank you very much for inviting me. It's really a pleasure to be with you this evening. I only regret not to be here in Argentina, but clearly that's something which is going to be complicated in the months to come. So the topic I was given is how do we cope with first-line treatment? What would be the standard first-line treatment for a patient with sarcoma? We are going to see, and we know already that this is not an easy topic because we have basically two options when we try to do that. We have the options of building on the clinical practice guidelines, which are as strong as they can be in a context where we have a group of very rare tumors with sometimes limited level of evidence, where we probably can push the evidence to some extent to guide us, but where there is a lot of uncertainties in different directions. What is interesting in this perspective is that sarcoma being a group of very rare entity, and that was one of the questions that was raised a few minutes ago. We really have to consider the fact that we are not dealing with a single disease. And this is even more important for the metastatic phase than for the adjuvant or neoadjuvant phase, even though the adjuvant and neoadjuvant phase inform us a lot, as we are going to see immediately, on how we should do the treatment. But anyway, we are speaking of a group of disease which is altogether very rare, but with probably in the last classification, which has been just reported a few weeks ago of WHO, there is over 150 different histotypes. So by definition, we are largely, for the majority of these histotypes, under one new case per million inhabitants per year. And these numbers, which we see here, are probably a bit outdated and do not reflect the global diversity of these tumors. It only reflects the fact that we are dealing with rare tumors. And by dealing with rare tumors, we are dealing with tumors which are very complicated to diagnose. When we try to look at that in different countries around the world, we all came with the same conclusion, that for these rare tumors, we first need something which is crucial to be sure to have the right histological and sometimes, as we are going to see, molecular diagnosis. Why is that? Because of course a pathologist is not seeing as many sarcomas as much as breast cancer, and the diagnosis is complicated, and some tumors are going to be seen only once in the professional life, or sometimes once in 10 years. For this reason, the diagnosis of sarcoma by an unexperienced pathologist is sometimes misleaded, and we have seen all together, all around the world, almost the same numbers of about 30% of inaccurate diagnosis if not reviewed by the reference center. So the first message I would like to convey, and that's important as well as we are going to see in the advanced phase, is to be sure of the diagnosis and to make sure that the diagnosis is appropriate, because, and we cannot blame anybody, that's because it's so rare. Central pathology review is useful because it enables to refine the diagnosis. It enables to refine the diagnosis, but this is not the only prognostic factor. And we have already discussed of the importance of the grade. We were moving actually in the last year from the histological grade, which is well known, which is the WHO grade, which is so predictive, as Javier just told us, of the efficacy of neoadjuvant or adjuvant treatment. Basically, we try to avoid grade 1 tumors for this type of exercise and focus on grade 3 tumors. But this is clearly an histological diagnosis. This is not a molecular diagnosis, and we have been moving in the last 10 years in the direction of a more accurate molecular classification of this disease. I think the one step that was accomplished some 10 years ago was about the classification using complex tools, expression arrays, in this case, enabling to define what is called complexity index in sarcoma, the SARC index, which is a genomic grading, if you can say so, which is useful, not very easy and not very well disseminated throughout the world, but useful to refine the prognosis. Actually, probably the next step, and actually the step we will be doing routinely, I'm sure, in the next 10 years, is to inform our diagnosis on genomic alteration. And you have a list of different genomic alteration in sarcoma, which are as complex as the histological diversity of sarcoma. So this introduction on the importance of histological diagnosis, an accurate histological diagnosis, and molecular diagnosis is really telling us that this is crucial to guide the best treatment. So Javier already covered the topic of first-line in localized phase, and I don't want to redo the presentation, but I think several things that he has told us are extremely important to inform the advanced phase. The first one probably is the role of neoadjuvant. And this study is an old study performed by the RTC, but during a long period of time, just before the ISG study, which was presented by Javier, this was one of the few randomized, or the only randomized study testing neoadjuvant chemotherapy, in this case versus no treatment, in patients with operable tumors, meaning possible amputation. And this study failed to demonstrate the value of chemotherapy. And this is not because chemotherapy has no value. It's because we were lumping different histological subtypes together, so the power was not there. We are mixing apples and oranges. Also, one important observation in neoadjuvant setting is that we should not think only of drugs. There are other tools which need to be investigated further. We are not doing this investigation enough, I think. I think the work which has been done by our German colleagues and colleagues from Netherlands and Belgium on the use of hyperthermia in combination with chemotherapy, in this case, both in the neoadjuvant setting in operable tumors and in advanced tumors, because this was a mixed bag of different sarcoma, proving that hyperthermia, focal hyperthermia, was useful to improve the quality of response, is also very informative. And I think that's something we should study further. The technology is expensive. It's not spread around the world. Actually, very few countries are using that. But that is one of the studies where improvement in survival have been demonstrated. And we should think of that in advanced phase for the future. Last thing where the neoadjuvant setting informed us on what we should do in the advanced phase is this ISG 1001 study. What is crucial here, and I think that the way forward is that it tells you that we have to treat according to the histological subtype. So, okay, the experimental arm was negative, inferior, sorry for that, overall. But what this is telling you is that not all chemotherapy do the same efficacy in a given histological sarcoma subtype. And we are misled if we would continue to do treatments in advanced phase or in any phase without looking carefully at the histological subtype. We are not there in 2020. We were there 40 years ago and 30 years ago and even 10 years ago, but we should progress towards first-line treatment adapted to the advanced phase according to the histological and molecular subtypes. Okay, so moving to this field, I think there are three things that I would like to raise first. The first one is that in the last 20 years, we have expanded considerably the number of agents which have proven efficacy. Proven efficacy in the context of a randomized trial, in the context of an uncontrolled trial, in the context sometimes of a retrospective study, but proven efficacy so much that they are mentioned in the clinical practice guidelines. So that's the first message. The second message is also a message which is not enough, I think, communicated by all of us, which is a very consistent message all around the world with all databases. This was the RTC database, one of the first who told the story. But the point is that metastatic sarcoma is a curable tumor. It is a curable tumor in about 5 to 8% of sarcoma, even with the lousy drugs that we had in the 90s or in the 80s. This is not only surgical removal of the metastasis. Some patients are enjoying prolonged progression-free survival and survival without progression. Nobody knows who are those patients, what are the treatments they truly received, what are the molecular characteristics of this patient, but all series are very consistent in this plateau of patients around 5%. One unsolved question is, what are the characteristics of this patient and could we identify them better? Because you can see, identify them in all subgroups of sarcoma, all histological subgroups, all grades, all quality of response to first line, all histological subtypes. So this is something else which is transversal that we need to study further. And the third point I would like to raise is that we have been progressing a lot for some tumors, but not for all tumors. And GIST and intermediate tumors of intermediate malignancy so far in advanced phase have an appropriate survival, which is about 60 to 70% alive person at 48 months. We have progress also for soft tissue sarcoma, but not as well. We are probably now in the range of a median survival altogether, all sarcoma together, in close, as you can see on this slide, extracted from the database of NetSarc, from the French sarcoma group, but everybody has the same type of data. We are about 20 to 24 months median overall survival, and we move from 12 months to 24 months. One important aspect also, and I will stress that only this time, is that the outcome of patient, even in this advanced phase, is influenced by what was done in localized phase. Appropriate surgery by an expert center impacts on survival even in an advanced phase. All right, with this as an introduction, the rest is extremely simple, I would say. What is the standard treatment of first-line patients with advanced soft tissue sarcoma? For decades, we've been discussing on doxorubicin or doxorubicin ifosfamide. Now, everybody agrees that if we lump all patients together, putting aside GIST, of course, we are going to have in this randomized clinical trial, showed it very well, better quality of response, better progression-free survival with the combination of doxorubicin full dose and ifosfamide full dose. We cannot do that for patients above 60 unless they are perfectly fit PS0. We can do that for younger patients. This will have a limited impact on overall survival, which was in this randomized studies, the primary impact. Limited impact, not absence of impact, because median overall survival is different. And importantly, the p-value was 007, so not that far from 005, but no major benefit, and in particular, no major benefit at the end of the curve. So doxo and doxo-IFOS, at the end of the curve, we still have a 5%. The quality of response, if your aim is to obtain a response for an advanced disease, then you should choose, if the patient condition allows it, the combination of doxorubicin ifosfamide. Can we do better with other regimens? Our UK colleagues did a very nice randomized clinical trial comparing gemcitabine docetaxel versus doxorubicin Geddes trial, randomized study, very powerful, mixing again, as we all do, different histological subtypes. No difference in overall survival, no difference in response rate, no difference in progression-free survival, slight difference in side effect profile. Unexpectedly, GD was slightly more toxic than the doxorubicin. Our Japanese colleague just reported this year in the ASCO some similar type of results with an absence of superiority of GD, actually a slight inferiority of GD for the relevant parameters. So we cannot replace doxorubicin regimen by another regimen in all patient population. So should we never use GD? Of course not. We have some patients where probably GD is superior, but we have not asked the question this way, and probably GD could be useful in selected histological subtypes. Probably, by the way, doxorubicin and ifosfamide is not the right combination in other tumor types, in some tumor types, and for leiomyosarcoma, a lot of us are using doxo DTIC, but with a limited level of evidence in terms of randomized clinical trial. What we also know from first-line setting is that we can be misled by some trials. And I think this has been a very deceptive experience for the whole sarcoma community, who raise a lot of expectations on the olaratumab randomized clinical trial reported by our colleagues from the US, showing a beautiful difference in overall survival, but not in progression-free survival, at least not to a magnitude that we will consider significant in this randomized phase 1/2. And this led to a randomized phase 3 study, which sadly could not confirm these results. No difference with either parameter. So olaratumab, which was approved very rapidly on the basis of this randomized phase 2 study, was not approved subsequently on the randomized phase 3, was unapproved on the basis of the phase 3 study. Why did this happen? We can only speculate because nobody really knows that, but probably one of the key issue is that, again, we are mixing different histological subtypes in these randomized phase 2 studies, and that this difference that we observed here was probably related to difference we do not understand yet on the histological and molecular subsets of patients. So what all this tells you is that we will make little progress if we do not split tumor types according to histological subtypes and probably molecular subtypes. All right, now first line, we are relatively comfortable in saying that when we use cytotoxic, dox-IFO, maybe for leiomyosarcoma, dox-DTIC, or maybe Gemzar docetaxel could be options. But actually, the main progresses were obtained not from randomized clinical trial, but from prospective phase 2 studies, or sometimes even retrospective studies in this setting. And these progresses were obtained actually looking at the molecular biology of the tumors. So without spending too much time on the description of the molecular biology of these cancers, we all know that we have sarcoma with translocation, which are about 15% of the patient. We have sarcoma with amplification of long part of chromosome 12, Q13, 15, typical of liposarcoma. We have, of course, sarcoma with kinase mutations, mostly GIST. We have sarcoma with tumor suppressor gene losses. We have sarcoma with complex genomics, which are not yet characterized. Let's have a look at what are the progresses which have been obtained in these tumors, looking at targeted therapy based on the molecular understanding. Starting with translocation and starting with classical imatinib treatment, not for GIST, only for dermatofibrosarcoma protuberans, a rare sarcoma which is rarely relapsing after an appropriate resection by our colleagues, plastic surgeon or dermatological surgeon, and sometimes the patients are relapsing in distant parts, and chemotherapy is very useless. imatinib was demonstrated to be active and was actually approved in many countries on the basis of retrospective studies, which were later confirmed by this prospective study published by Piotr Rutkowski, putting together two series, which showed time to progression, which was very superior to what was observed previously with doxorubicin. Why is that? Because imatinib is blocking a kinase, which is activated by the product of the fusion gene observed in dermatofibrosarcoma protuberans. Understanding biology has an impact on treatment. And this is the first-line treatment which should be recommended. The same is true for a rarer, very rare sarcoma subtype, which is called inflammatory myofibroelastic tumor, IMT. This tumor is characterized often, not always, by ALK translocation, rarely by ROS1 translocation, even more rarely by NTRK translocation. In this case, we focused on all IMTs, and Patrick Shosky and collaborators used crizotinib, an ALK inhibitor, to demonstrate rigorously in the prospective setting the quality of response obtained by crizotinib. You can see here on the survival curves the outcome of patients treated with this ALK inhibitor, and you can see that these results are far better than what we observe with cytotoxic chemotherapy, in this case doxorubicin, even though some of the treatment which can be obtained with methotrexate and vinorelbine are quite satisfactory as well, but the number are small. Anyway, doxorubicin is not as good as targeted treatment based on the understanding of the biology of the tumor. And we have all seen the papers, very interesting papers on these super rare entities, which are the NTRK translocated tumors, including sarcomas, which you can find all over the body. We have seen the interesting data published in Lancet Oncology and New England Journal of Medicine repeatedly. And you can see here that for sarcoma, that is very impressive because we are speaking here of sarcoma with super rare translocation, 0.3 probably to 1%. The numbers are still not so clear. But when you have this translocation, we are speaking here of soft tissue sarcoma, put aside the pediatric sarcoma, put aside the GIST tumor, you can see that we have a quality of response which is unprecedented with complete responses which are observed a substantial proportion of patients, and almost all the patients, few exceptions, do actually respond. The same is true for the other one, entrectinib. You can see here, by the way, the duration of response and progression-free survival and overall survival for you are speaking here of advanced tumor who have failed the standard treatment. The same is true for entrectinib, but the number of patients are smaller. The trend is exactly the same. Quality of response, which is unprecedented and incomparable to what is observed in patients with treated with doxorubicin. And most of these patients, not all, were pre-treated with cytotoxic chemotherapy. So probably if you have an NTRK sarcoma translocation, if approved, you may want to treat this patient with NTRK inhibitors within the context of a clinical trial or within the context of approval if we are if our countries are approved for reimbursement. Finally, another example of not really a sarcoma, but a cousin tumor, the classical giant cell tumor of tendon sheets and soft part, TGCT, where a translocation which is observed is a CSF1 receptor translocation. And we have these huge tumors which are clearly non-operable. They rarely do metastasize, but they sometimes metastasize. I've seen myself a couple of patients on the about 100 patients that we've been following in the center. Super rare, but it happens. Nothing is working. Chemotherapy is useless. Radiotherapy not useful. But because CSF1 can be targeted by imatinib, which blocks CSF1 receptor, we did these retrospective studies, this prospective study, which all led to the same conclusion that if you block this pathway with CSF1 receptor antibody or TKI, you have responses, and the most impressive responses were observed with pexidartinib, which was designated specifically to block CSF1 receptor, with a quality of response which is, I think, best demonstrated by a picture which was shared by Silvia Stacchiotti from Milano, who had this patient with a dreadful tumor, this dreadful tumor on the hand. You cannot see the fingers, and after a few months of treatment, the patient obtained a very good quality of remission. You can see now the fingers, and that's unprecedented. And of course, you may want to have a non-conservative surgery in this case without this treatment. So benign disease, yes, okay, benign disease. What is the meaning of benign disease? You may discuss on that. We would be happy if we would have always that. This is not the case. We sometimes have other alterations which are less easy to target. The classical amplicon on chromosome 12, which amplifies MDM2 and CDK4, the usual suspects in liposarcoma, is an ideal target because that's almost the only genomic alteration. And you could say that single agent therapy is going to be useful. It is useful, but only to a minor extent. If you use an MDM2 inhibitor of CDK4 inhibitors, the response rate is in the range of 5%, and very few patients achieve prolonged progression-free survival. Median PFS is always in the range of 4 months. What we are doing now in several countries and centers is a combination of the two agents, which seems to provide better quality of response, about in the range of 30%. This is not yet published, and this is submitted for publication, and a longer duration, with some patients achieving years of tumor control with this combination. But this combination is not that easy to handle and associated with significant cytotoxic activity. If you're dealing with liposarcoma, with this amplification, low-grade liposarcoma in the retroperitoneum, you know that cytotoxic chemotherapy is not very useful. In this case, you may want to have this specific targeted approach once the drug will be approved. In this case, which is really an orphan situation, targeted treatment in a clinical trial may be the best standard option. Let's continue our analysis of the current literature, moving to TSC1 or 2 losses, which is characteristic of a family of tumor called PEComa. The team from Milano beautifully described a retrospective study of what was happening to PEComa patients with advanced phase with anthracycline, gemcitabine, VEGFR2 inhibitors, and mTOR inhibitors. So you remember that if you have an inactivation of TSC1, TSC2, you will have an activation of mTOR. And mTOR can be blocked by a specific medication, which are currently being used in a lot of settings. What this study, retrospective study done on multiple countries and led by our colleagues from INT, told us is that indeed mTOR inhibitors had a high level of activity in this tumor. Look at here the response rate in a range of 40%, much higher than anything else. And the majority of these patients were given in first-line setting. And the disease control rate was high, and the duration of PFS was much higher than the rest. So here you really have something which is of importance, and you can see here on the survival curve, which is much more favorable than what we have with gemcitabine or even with doxorubicin, with, of course, a less challenging treatment in terms of side effects. Let's continue on another model where we are speaking of desmoid, again, not sarcoma, but cousin tumors. We have two interesting studies, a very nice study of our colleagues from New York comparing sorafenib versus placebo, showing a difference in progression-free survival, and the study performed by Italiano and colleagues, which showed that actually this class of agents, in this case regorafenib, was equivalent to cytotoxic chemotherapy, in this case vinblastine methotrexate, classically given to this patient population. Here, doxorubicin is not relevant. This class of agent is probably very relevant, or maybe cytotoxics, because they seem to provide similar signals of activity. To conclude my talk, I would like to spend a few minutes on sarcoma with complex genomics, not to find the solution, because this is a mixed bag. That's about 40% of sarcoma patients, and we are still working on what is the best treatment for these patients. We are speaking here of UPS, we are speaking of LMS, and many pleomorphic sarcoma of all kinds that we do not know really how to treat. But sometimes we have clues. And in the case of epithelioid sarcoma, which are characterized often by an INI1 deficiency. INI1, as you know, is a complex which regulates PRC2, and PRC2 is currently regulating the expression of a series of genes which are not fully characterized, by the way. The point is that with epithelioid sarcoma, epigenetic dysregulation could be targeted using an EZH2 inhibitor, in this case tazemetostat, which provided, as you can see on patients patients without previous treatment a significant tumor control as compared to what is usually being reported in this sarcoma, which are very difficult to treat epithelioid sarcoma. 21% response rate, not necessarily impressive, but you can see that these responses are very long lasting. And this is probably what is the most important observation here, is that we have about 20% of the patients with long-lasting responses. The drug is approved in the US, not yet in many countries around the world, including our countries, but that's certainly something that we need to look at look further. I wanted also to spend a few minutes on the study which was focused on bone sarcoma that was done in the French sarcoma group, looking, as we all know, bone sarcoma in relapse are very difficult to treat, with the possible exception of Ewing, where there are some treatments which are working, but for osteosarcoma, for chondrosarcoma, and for chordoma, very little is known. Dufault and collaborators published on osteosarcoma and published that regorafenib, without a very accurate understanding of what was going on, was able to prolong progression-free survival to something which is a relevant extent without an impact on overall survival. But there was a crossover. Anyway, this is a drug which is not registered for this purpose, but which provides a solution in first-line setting of metastatic osteosarcoma, because they have been receiving all the drugs beforehand in neoadjuvant and adjuvant setting, as we all know. I would like to finish with using immunotherapy. Immunotherapy, we all know that, and that's well identified here, has been more or less a failure in sarcoma. But this is again because we probably did not understand what was going on. And several basic researchers have been publishing a very interesting observation on the fact that the presence of tertiary lymphoid structure in sarcoma, B cells, T cells in tertiary lymphoid structure, was associated with a quality of response with, which was higher in sarcoma. That was a retrospective study, and that was exactly what was described in the case of the presence of a TLS and with a survival curve. So this is currently being confirmed in a prospective setting. What I can tell you, even though it is not published, that is that the tertiary lymphoid structure is very rarely observed in sarcoma, but when it is observed, it really provides you with a population of patients which is going to respond in a high proportion, and sometimes with prolonged progression-free survival. So this needs to be looked at further, and that's something that is clearly superior in this small group of patients with sarcoma with complex genomics, with a quality of response and duration of response which will be superior to doxorubicin-containing regimen that we've been using for 50 years. A very nice example of the use of immunotherapy on the dedicated histological subtypes is this combination of axitinib plus pembrolizumab in different sarcoma subtypes, but with a strong signal for alveolar soft part sarcoma. We are going to report this year in ESMO a dedicated trial on these patient populations. I've reached the end of my presentation. As you have understood, we are dealing with a complex group of disease which should not be treated the same. The first step is really to be certain to have an accurate diagnosis. In reference centers, we have it. This is not always the case everywhere, simply because these diagnoses are complicated. We need to have an appropriate first-line treatment adapted to these histological and molecular characteristics. This is changing the practices, and we are going to have to move away from a one-size-fits-all approach to an approach where we are going to give first-line treatment which are going to be adapted to the histological and molecular subtypes of sarcoma. Thank you very much for your attention.
Thank you, Shanips. Thank you very much for your excellent conference. We have in the gate Chris Corliss, who is going to bring some. Oh. Yeah, Chris Corliss is here and is going to bring to us some news about GIST pathology. But first of all, we have to discuss. We have some questions from the fellows to Shanips. For us, it's a privilege, so please be free to ask some question. Shanips, which is the case? You finished your talk with that our first line in sarcoma is going to be only doxo based, but which histology you preserve the patient to do not perform doxorubicin or isofosfamide?
Actually, all the sarcoma with translocation, if we get information in the first place, we are going to give an a targeted treatment. We would extend that to the rare sarcoma with specific missense mutations such as BRAF, because well, this is going to be published, but the response are also high. For MDM2 CDK4 and the example I provided, we are in a more difficult situation because this is clearly not, these are not agents which are registered for the combination. CDK4 single agent has limited activity, even though there is a signal, it's not long lasting, so we will not change our policy right now. As soon as this is going to be demonstrated in a prospective study, possibly things will change, in particular for low-grade liposarcoma. Tazemetostat is a good example. For PEComa, we use that for alveolar soft part sarcoma. Well, the list is expanding, but still, I've not made a calculation of what's the proportion, but I would say that probably still 75% of the patients with sarcoma still require doxo ifosfamide first-line treatment or based first-line treatment, but we are slowly expanding the number of indications on dedicated treatment.
James, do you consider as the volume of disease as a biomarker to prescribe combination therapy or single agent?
Yeah, yes, often, because actually the key question for the combination is really to shrink the tumor to an extent that the surgeon will think that this is feasible to obtain complete remission. So the bulk of the tumor itself, in particular, if oligometastatic or even only locally advanced, is a crucial parameter for that. But that has been already mentioned, I think, by Javier, that we start always with combos when our aim is to obtain a complete remission if we shrink a bit the tumor. Yeah.
And how many lines do you have your patients at your clinical daily practice in advanced disease?
I cannot tell you an exact number, but on the top of my head, the impression I would say that the majority of sarcoma patients receive 3 lines or more. Basically, we have docs first line or sometimes neoadjuvant setting, more and more often in neoadjuvant setting. So they will receive probably trabectedin or gem-based afterwards, and pazopanib afterwards, and then phase 2 or 3 trials in between. So of course, patients are dying during this patient pathway, and we are losing some patients. But last time we looked at that, and we had a retrospective study on that. I think the median was 3. It's probably still in this range.
Okay. Well, Janib, it was a really pleasure for us to
thank you very much for the invitation.
You are near midnight, so we leave you. So very thank you for all the fellows from Argentina and for Silent Partners. So thank you.
Thank you, Matthias. Thank you, and hello, Chris.
Thank you. Hi, Chris. Well, it's a really big pleasure for us to have you. Chris Corliss is the professor of pathology at and vice chair of the molecular pathology and director Night Lab and Cancer Institute from Oregon. So it's really a very good pleasure for us to have an excellent pathology that could and that can speak about medical oncology, and all the clinicians really appreciate your participation here. We are the fellowships of medical oncology in Argentina, so we are going to hear you about the news in pathology in GIST. So thank you very much, Chris, for your participation.
Well, thank you very much, Matthias, and best regards to Jean-Yves, and enjoyed his presentation. Every time he speaks, I always learn something, and so I'm happy to sit in on his talks. Can you see my screen okay?
Not yet.
Okay, I'm sorry. I will try again to share.
We are seeing the cars that are
okay
behind you.
This is my office, so
very nice tree.
Yeah. Okay. I'm going to try again to do the presentation mode here, and I was hoping that this would project properly onto this screen. How about now? Is it still the cars?
And still the cars.
Okay, I'm gonna try a different tact then. We'll try this. And how about now?
No, Thomas, do you want to help him, or do you want to share the conference or the slides, or?
Yeah, it's a large file, so it would be difficult to share it
Okay.
quickly. Let's see, I'm trying to figure out if there's another way in which I can try to.
Yes, you are co-anfitrion, so you don't need my authorization.
Okay, yeah. So let's see, share screen.
Okay.
Is this better?
Yeah.
Okay.
Excellent.
And how about now? Is that the full screen?
Yes.
Yes, we can see now.
Okay, very good. Thank you. Thank you for your patience. I appreciate it. I do hope that Argentina is managing the pandemic better than the United States. You know, the United States always prouds itself on being #1 in the world, but right now, #1 in the world is not the good place when you're talking about the COVID. I hope you're doing better. In any event, happy to join you remotely. My goals this evening are to talk about molecular diagnostics for sarcomas. I will start with the topic of GI stromal tumors because that's probably the one class of sarcomas which we understand the best. I'll then touch on some of the technologies that we use and specifically next generation sequencing. And then I would like to give you some examples of how we look for gene fusion events, which are important both in the diagnosis of sarcomas and increasingly in targeting them with specific therapies. So to remind you, GI stromal tumors can arise anywhere within the GI tract, most commonly within the stomach, but also in the small intestine, the colon, the esophagus, and so forth. And the tumors generally will present as a discrete mass, a round mass like is illustrated here. We have, of course, been targeting these tumors with inhibitors for KIT and PDGF receptor for now 20 years, which is actually hard for me to believe, but the time has gone by quickly. And we do this because most of these tumors have mutations in these genes, and these mutations are responsible for the growth of these tumors. Now, where do the GI stromal tumors come from? We think that the most common type of GIST, which has a KIT mutation, arises from a class of cells within the wall of the GI tract called the interstitial cells of Cajal. And these cells can be highlighted by KIT staining. So they are positive for CD117 staining. And they have many other features that are shared in common with GIST. So this is what we think is the cell of origin for most GI stromal tumors. The tumors that have PDGF receptor alpha mutations probably arise from a different population of cells within the GI tract called the telocytes. These cells are very similar to the ICC cells, and all of them serve as a network that coordinates signaling between the neural cells and the smooth muscle cells so that you have peristalsis of food throughout the GI tract. Now, it turns out that there is a very large population of mini GISTs, very small GISTs, less than 1 centimeter in size, within the general population, especially people over the age of 50. You can find many of them will have one or more of these mini GISTs within their stomach. They're less common in the rest of the GI tract, although there's less study that's been done of it. Interestingly, these mini GISTs have positivity for KIT staining as well as DOG1, and the same kinds of KIT mutations that we see in the clinically important GISTs. So this is a situation that is similar to prostate cancer, where there is a large number of tumors within the older population, but only a small fraction of those actually become clinically important in any given year. So this is kind of interesting, and it tells us that GISTs have a very large population of slow-growing, basically benign lesions, and only rarely do they become malignant. Now, the purpose of the KIT receptor and the PDGF receptor alpha is to serve as binding of a ligand. And in the case of KIT, the ligand is stem cell factor. And stem cell factor is a dimer, which will bring two KIT molecules into close proximity. This dimerization event leads to activation of a kinase. ATP is used to phosphorylate signaling intermediates, and that will then lead to signaling through the MAP kinase and AKT pathways. So this is the situation in the normal ICC cell, or the normal melanocyte, or mast cells, and other cells that are dependent on KIT. In the mutant situation, however, the kinases no longer require any ligand. They will spontaneously dimerize and create this ongoing signaling, and that's what forces the hyperplasia and eventually outgrowth of a tumor from ICC cells or telocytes into something that becomes clinically significant. Now, there are other mutations that are required to become malignant, but this is probably the primary original event that leads to the development of a GI stromal tumor. And of course, the idea of using a targeted therapy like imatinib is that it will bind to the kinase domain of a molecule like KIT and will turn off the signaling and withdraw the support for the cell growth. And you can see that in PET scans very nicely. So here's a patient who has a GIST that's metastatic in the abdomen, and after 5.5 months of treatment with imatinib, all of the tumor has basically disappeared, at least metabolically, and the patient, has a very good response. But note that even after just 24 hours, so that's one dose, one 400 milligram pill, you already have a decrease in the signal inside the tumor cells. So when you can block the mutant KIT with a drug like imatinib, you can have a profound effect on the growth stimulation and the glucose uptake by the tumor cells. So that's the good news. The bad news, though, is that this does not always kill the tumor cells. Oftentimes, it just suppresses their growth and puts them more or less into just kind of a stasis situation. So the other thing we need to keep in mind is that although we can see very profound responses like this, it's not true for every patient, and some of the response is dictated by the underlying mutation that is present in an individual tumor. So let me illustrate that for you a little bit more detail here. It turns out that 3/4 or 75% of GI stromal tumors will have a KIT gene mutation, and these are sensitive to imatinib, but the sensitivity varies a little bit. And about 10% of GIST will have a PDGF receptor alpha mutation. Among these mutations, the ones that are in exons 11 or 12, and these are homologous between these two kinases because they're very closely related to each other. All these mutations are sensitive to imatinib at 400 milligrams. But the exon 9 mutation seen here in some of the GISTs, particularly the small bowel GISTs, requires a higher dose. So 400 milligrams is really not enough for exon 9. You need to treat the patient with twice the dose of 800 milligrams. And then we have mutations that can be completely resistant to imatinib. This one, D842V, 5% of all GI stromal tumors. This needs to be treated with a different drug. And fortunately, in the last 2 years, we've had new drugs being developed, whereas before we had nothing to offer for these particular patients. Okay, so far I've emphasized in the story of GI stromal tumors that there are KIT mutations and PDGF receptor alpha mutations, and that all of these comprise about 85% of the tumors. And then we can treat these with imatinib or with another kinase inhibitor that will shut off the signaling and slow down the tumor growth. However, there are 15% of the tumors which are wild type for KIT and PDGF receptor alpha. And these ones are much more difficult to manage because they are downstream of KIT and PDGFRA. So we may have GIST with NF1 mutations, RAS mutations, BRAF, NTRK3, or most commonly, loss of succinate dehydrogenase activity within the mitochondria. This results in a cell that can no longer convert succinate to fumarate, and excess succinate has impacts on the cellular metabolism, including increased HIF1 alpha activity and decreased DNA demethylation. So the biology of these types of GI stromal tumors is very different from the KIT and PDGFRA. These tumors show very poor responses to KIT and PDGFRA inhibitors, and it's necessary to use other types of therapies. Now, to identify the SDH deficient GIST is actually quite straightforward. You can do an immunostain for SDHB protein, and what you'll see is that there'll be a little bit of residual signal in the capillary endothelial cells, but the tumor cells will have complete loss of SDHB. When you see that, you know it's an SDH deficient tumor, and you know it will not respond well to imatinib. Importantly, these kinds of mutations that occur in any one of these genes, SDHA, B, C, or D, these are often germline or inherited. And when they are, the patients are not only at risk for GIST, but they're also at risk for the development of paraganglioma and other tumors within the abdomen, as well as in the brain. And what's very interesting is if you look at individual families that have a germline mutation, you may have one person who develops GIST, another person who develops paraganglioma, and then the sister or the father or the son may have no tumor whatsoever. So the penetrance and the types of tumors that develop in these patients is highly variable, even if they all have the same mutation in the germline. Okay, so that's SDH deficient GIST. So we can summarize then the whole story of molecular subtypes of GI stromal tumor with this pie chart. Again, we can use imatinib to manage most of these mutations. 400 milligrams will work for most of them, 800 milligrams for the exon 9. However, if we're dealing with some of these other mutations, we're going to have to use a different drug like avapritinib for the PDGFRA mutations, or a BRAF or NTRK inhibitor for these very rare forms of GI stromal tumor that have mutations there. And for the SDH deficient GIST, unfortunately, we still do not have a very good therapy, and there needs to be more work done to advance the care for these patients. Okay, I'll be happy to stop here and ask if there's any questions at this point, or otherwise we can move on and talk about our next topic.
Chris, thank you for your talk about subtypes of GIST. Do you consider that, well, first of all, it's for fellows, so I guess that it's very important to introduce you as one of the pathology that discovered the mutation of the PDGFR. Can you send or just tell a brief history about the PDGFR history?
Yes, so the KIT mutations were discovered by a pathologist in Japan. And he had the insight to understand the relationship between ICC cells and GI stromal tumor cells. And that's how he discovered KIT mutations. We recognized early on, my colleague Mike Heinrich and other colleagues at the Dana-Farber Cancer Institute, that there were GISTs that did not have KIT mutations. And so we wanted to understand what else might be driving those tumors. And one of the observations from RNA expression analysis was that some of the tumors expressed high levels of PDGF receptor alpha. This prompted us to look for mutations in the PDGFRA gene, and we found those and we published them in about 2003. So it was fun to be having a chance to participate in the early molecular dissection of these tumors. And it's been fun also to see how drug development has continued over the last 20 years. And bit by bit, we get better and better at managing these patients.
So can we speak as in breast cancer that we have all the cysts are involved in some mutation, or do you consider that still there are a wild type cyst?
There are still a few. I think it's maybe only 1 or 2% now.
1 or 2%.
Where we cannot find something. But it's rare. It's very rare. So yeah, we feel like we have a better handle on GIST even than we do on breast cancer or lung cancer, for sure. Yeah.
Do you consider, Chris, that the genotyping is going to be performed as any cyst as we perform hormonal receptors in breast cancer or HER2/neu? Do you consider that every cyst should be tested for any of the genetic mutation that we know? And which is your, yeah.
Well, so here's my recommendation. Some of the GISTs that are discovered in patients are small and have no mitotic activity, maybe 2 centimeter GIST in the stomach, and maybe it's removed surgically, but at that point, the patient is probably cured. The risk of recurrence is very low. So in that situation, I do not recommend molecular testing because it's spending money that you don't need to spend. But if there is a question of using imatinib as an adjuvant therapy for a higher risk tumor, or the patient presents with metastatic disease, then I think it's very important to do the molecular testing so that we can choose not only the right drug, but also the right dose.
Excellent. Do you consider in those cysts that you require neoadjuvant therapy? So do you consider to perform testing or genotyping those patients that are going to be treated by previous with imatinib of rectum or a huge tumor in the stomach or duodenal cyst?
I think it's a good idea. It's not always done. Sometimes they just, they go ahead and treat and then they look at the CT scan results after 6 weeks or 10 weeks and make a decision about surgery. So I would say neoadjuvant, it's not always done. However, for adjuvant, after surgery, where there's a high risk of recurrence, then I think it's very, very important to do the testing. Because you don't want to put a patient on a drug for 3 years if that drug is going to have no impact.
And in the population of the PDGFR GIST mutation, do you consider that there are some patients or some GIST with this mutation that are sensitive to imatinib or sunitinib or regorafenib, or all are resistant?
So some of the PDGFRA mutations, exon 12 and exon 14, for example, are sensitive to imatinib. And it's really only one of the subtypes of exon 18 mutations that is resistant. So that requires a different drug. Yeah. Okay. And I think there's going to be a second drug approved shortly, if not already, for that type of mutation.
Yeah, avapritinib is the drug that was approved. Yeah.
Yeah. Yeah.
Well, do you have do all the fellows have any additional question to GIST and molecular? Because this is a very excellent opportunity to ask Chris to someone else. You can do it in Spanish and we translate in our Spanglish. Go ahead, Tomás, Andrés, Federico. Well, Chris, if you want to continue.
Okay, we'll go ahead, and again, we'll have more time for questions later.
Matías, these questions, Cristina, Mariana.
No,
I think that I'm able to make the question. I didn't understand the difference in terms of imatinib according to the exon. Does it has to do with the location of the domain, that it's extra or intra, or I don't know.
Yes, that's a great question. So the exon 9, the exon 9 mutation, I hope you can see it here on this slide, is extracellular and does not directly influence the shape or the activity of the kinase domain. Instead, it enhances two KIT molecules coming together. The exon 11 and 13 and 17 mutations are all on the inside of the cell, and all of them change the actual conformation of the kinase so that it is more turned on by itself. And that turns out to be more sensitive to imatinib than the exon 9, which is more like a wild type KIT. And that's why the exon 9 needs a higher dose.
Okay, thank you.
Yeah.
So we can go ahead, Chris.
Very good. So let me move on then to next slide, which is I'd like to introduce next generation DNA sequencing. Now, I know this can be very boring to people, so I'll keep it very short. The technology is interesting I know is interesting to me, but most people don't think it's so interesting. All right. Traditionally, DNA sequencing has been done using the Sanger methodology, which is illustrated on the left. Today, we are now using next generation sequencing, which gives us an output that is illustrated on the right. So the difference between these two technologies is basically the difference between a black and white TV that we had in my house when I was a little boy, and yes, I am that old, to the kind of thing that we have today, which is digital TV, and we have hundreds of channels. Okay, so this is an analog output. The Sanger sequencing is analog. The next generation sequencing is digital. And the way that we conduct the sequencing is illustrated on this slide. This is a very crude diagram. It's not giving you much detail, but I hope to just get across the basic point. The DNA that we want to sequence is distributed across a glass slide at very low density so that individual molecules of DNA after local amplification can be sequenced, and we can follow the color change as nucleotides are incorporated with each cycle. So basically the modern sequencers from Illumina, and this is the kind of sequencer that we have in our laboratory, these sequencers will follow the color change of the nucleotides one cycle after the next across every spot on a slide. And the number of spots is actually very impressive. The latest sequencers can now follow more than 2 billion spots on one slide and follow the color changes for all of those spots during 24 hours of sequencing, which is about 150 base pairs. Okay. So ultimately, each one of these spots corresponds to a unique piece of DNA. And ultimately, we will assemble all the information back to determine what is the sequence for an individual tumor sample. Now, let me show you the difference between these two types of technologies with an example from GI stromal tumors. Here is Sanger sequencing that we performed on a GIST. This tumor, we're looking at exon 18 of PDGF receptor alpha. And we see right here that there's this mutation, this T and A are overlapping. And that means that there's a change of aspartate to valine, which is the D842V mutation resistant to imatinib. But also in the same sequence, we see overlap of these peaks because one of the alleles is missing this C. And this is what we call a frame shift mutation. Now that's very strange because this mutation is a known GIST driver mutation, but this mutation will truncate the kinase domain and completely inactivate the PDGFRA. So when we saw this, we did not understand it. We said, well, how come we have both of these mutations? What's going on here? Because they are conflicting in how they will affect the PDGFRA. The answer came from doing next generation sequencing. And now with each of these gray bars, we are looking at individual molecules of DNA that have been sequenced. And you can see that all of the ones that have the mutant T right here that gives you the D842V, they are different than the reads that have the missing C. And that tells us definitively that the D842V mutation is on one allele and the missing C is on the other allele. So what happened in this tumor was it gained a mutation that is oncogenic, and it also knocked out the remaining wild type allele with this frameshift mutation. And with Sanger sequencing, we cannot see that, but with next generation sequencing, it is clear as day. Very, very clear answer to the problem. Okay, so that's the power of next generation sequencing, and we use it for evaluating sarcomas all the time, as we do for many other kinds of solid tumors and for leukemias. So our laboratory now does about 2,500 next generation sequencing tests per year. And we're always trying to find things that are diagnostically helpful, prognostically important, and also predictive for response to therapies. And so here are some examples for common sarcomas. Liposarcomas, of course, have MDM2 amplification and CDK4 as well. We often see P53 and retinoblastoma mutations and losses in these other types of sarcomas. Now, unfortunately, these are not terribly approachable right now with the current therapies. And so this kind of information generally will not change the management for an individual with this type of sarcoma. On the other hand, we have the sarcomas that are driven by gene fusion events. And these can be helpful in two regards, both for diagnosis and also for treatment. And so we have in Ewing sarcomas, the Ewing's gene, EWSR1, can be fused with a variety of different other partners, or it could be an FUS gene fusion that is driving the Ewing sarcoma. And then there are the CIC sarcomas and B-core sarcomas, synovial sarcomas, and every one of these may have one or more type of gene fusion event that is responsible for that particular type of sarcoma. So for the pathologist who is trying to come up with a diagnosis of a particular sarcoma, it can be very helpful to identify these types of gene fusion events. And we have several ways in which we can do that, and I will illustrate those for you in a moment. But again, I want to also emphasize that we have a number of gene fusion events in sarcomas that are not only diagnostic, but they are therapeutic targets. Because ALK, BRAF, RAF, RET, all of these genes are kinases, and all of them can be targeted with one or more different types of specific therapies that are available these days. Okay. So let me give you an example of what is going on with some of these targetable fusion events. And here we're looking at the family of NTRK genes, which can be involved in gene fusions, as Dr. Blay mentioned in his presentation. So NTRK1 or 2 or 3, any one of these may be fused with another gene. And commonly the arrangement is as is illustrated here. The kinase domain of the TRK gene is fused with some type of 5' partner gene. And that then leads to spontaneous dimerization, very similar to to what we saw with KIT, but now we're talking about inside the cytoplasm. And this turns on the TRK kinase domain. So it's the partner is contributing a protein domain that is causing the dimerization event, and that activates the kinase and causes the growth of the cells. Okay. Here's an example of an ETV6 NTRK3 fusion that is seen in several sarcoma subtypes. And here are the native conformations of those genes. So the ETV6 has the SAM domain, the NTRK3 has the tyrosine kinase domain. Those two get fused together. Notice the transmembrane domain and the extracellular part of NTRK3 are gone. And all we're left with is a kinase domain that is being dimerized by virtue of the SAM domain being fused to it. Okay, so this is the kind of thing, this theme is generalizable across all of those targetable kinases, NTRK, BRAF, RAF1, and so forth. They all have this basic theme that's happening and driving the biology of those particular sarcomas. And of course, the importance here is that we have two drugs that are FDA approved for treating these tumors. And as Dr. Blay emphasized, the responses are very remarkable for these drugs, and it's providing a nice benefit to the patients who receive them. Now, one of the class of tumors that harbors these kinds of fusions is infantile fibrosarcoma. This is, of course, a pediatric tumor. It may present at birth. It may present at year 1 to 3 of life. Can occur in many different locations within the body. Under the microscope, challenging diagnosis for the pathologist. There are some features that are characteristic, but it's not always possible to make the diagnosis just from the H&E stain. So commonly, people will use immunohistochemistry, and one of the best markers is the pan-TRK antibody. This antibody will stain NTRK 1, 2, or 3, doesn't matter. And if you see strong expression, as we do in this particular example, then that is a suggestion that the tumor may have a TRK gene fusion. And as it turns out, most infantile fibrosarcomas will have an ETV6 NTRK1 fusion. That was the original fusion that was identified, and for many years it was thought to be the only fusion in these tumors. But more recently, we've learned that we have to actually expand the molecular definition of fibrosarcoma to include fusions of NTRK 2, 3, or RET, or BRAF, or so forth. Okay, so as with other types of sarcomas, the molecular complexity is growing, and there is not a one-to-one correlation between the name of the tumor and the molecular biology. And GIST is another example. We talked about in GIST how they all have the same name, gastrointestinal stromal tumor, but there are many different molecular subtypes. Same story here in infantile fibrosarcoma. Okay, now, IHC, immunohistochemistry, is one approach that you can use to suspect that there is a fusion gene present. And many pathologists will use this as a screening tool. The other technology, of course, that has been around for a long time is fluorescence in situ hybridization. And this is an illustration of a very typical type of FISH test. In this case, we're looking for an ALK gene fusion. And this type of FISH is called break-apart FISH. So in this type of assay, we have a probe on the 5' end of the gene and a probe with a different color on the 3' end of the gene. If the ALK gene has been broken by a translocation, these two probes will suddenly become widely separated from each other in the nucleus. So the normal situation is illustrated on the left, and the green and orange probes are together. But in the tumor cells with a ALK fusion, the orange and green, orange and green probes are separated from each other here and so forth. So this break apart is diagnostic of something that has interrupted the ALK gene and reflects the presence of a gene fusion. So FISH is very commonly used in cytogenetic laboratories around the world. It's one of the standard approaches for detecting gene fusion events, and it can be very, very useful. So when I look, though, at the complexity of all the different gene fusion events that we are concerned about in the diagnosis of sarcomas and in the treatment of sarcomas, I find that immunohistochemistry is really not enough. It works for some genes, but it doesn't work for all of them. And the same is true for FISH. Yes, we could create FISH assays for all the targets that I've listed on this slide, but if we ran all of those, we would run out of tissue and we would run out of money. So we do not think that FISH and IHC are really the best approaches to doing fusion gene detection these days. We now favor using next generation sequencing. And the way that we do that is there are two different approaches. Some laboratories will sequence the DNA and they will look for areas within the introns where there is a fusion event, because most of the gene fusions occur in intronic DNA between specific exons. And so here I'm illustrating for you the EML4 ALK fusion that can be seen in inflammatory myofibroblastic tumor, but also, of course, in lung cancer and other cancers. And so here we have the intron from EML4 has been broken, and now it's fused with this intron of ALK, and that is the actual translocation site. This approach works. Many laboratories use it, but I can tell you that it is challenging because the intronic regions of these genes can be very large. And so if you want to have a comprehensive panel, the amount of sequencing required to look across all these introns for possible fusions is daunting. It's actually almost impossible. So for that reason, our laboratory and many other labs now have moved over to doing RNA sequencing. Because in the end, if you have a fusion product, this exon and this exon are going to be fused together, as illustrated here, in the final spliced RNA product. And all we need to do is to detect this fusion here. We don't need to sequence all this intronic DNA. All we need to do is sequence one little area here in order to detect the presence of the fusion. The current generation of assays that we have set up are now set up such that it's possible to sequence in one direction from, say, ALK and find any partner that is present on the other side. So this allows us to generate a so-called partner agnostic approach. This is the RNA sequencing panel that we now use in our laboratory for the last 3 or 4 years. It has about 20 targets on it that are mostly actionable with drugs that are available for sarcomas and other tumors. Again, it is partner agnostic. We can find any partner that is fused to one of these genes. And it's relatively inexpensive to do this because it doesn't require very much sequencing to run it. One of the things that we found recently, and we're about to report, is a new RAF1 gene fusion in an infantile fibrosarcoma. To our knowledge, this is the first RAF1 fusion that has been seen in this type of tumor. So we're expanding the molecular information about fibrosarcoma, and we happen to find it by doing this particular RNA sequencing approach. Okay, now this approach is focused on genes that are targetable with drugs that are available today, but it does not find all of the fusions that can be present and diagnostic for other purposes. And some of those, like the ones I mentioned in Ewing sarcoma and alveolar soft arch sarcoma and so forth, those are not seen by our panel. And to find those by sequencing, we have to do what's called whole transcriptome sequencing. We don't do this every day. We do this only once or twice a month. But we will run it on sarcomas. It is expensive. It's about $2,000 US, which is not something that we're anxious to spend unless it's really important. But I'll give you one example. Recently, we sequenced a high-grade uterine sarcoma, and we expected to have a NTRK fusion in that tumor because the tumor was positive for IHC with the pan-TRK antibody. The RNA sequencing was negative for a TRK fusion, so we did the whole transcriptome and we found a SAMD5 SASH1 gene fusion event. This was a complete surprise. It's only been reported one time before in a chordoma. This tumor was not a chordoma. It's not actionable, but it's new, it's novel, it's interesting, and it's one of the reasons we like to do this kind of approach when we have to, because it allows us to learn more about the biology of these tumors. So now one thing that I wanted to just close out with is a glimpse into the future. And in the future, I think we're going to begin to see DNA methylation analysis play a big role in the classification of sarcomas. There has been a tremendous amount of work done primarily out of Germany, the University of Heidelberg, where glioma classification has been moved forward by the use of DNA methylation arrays. That technology is now being applied to sarcomas with equal success. And our laboratories are just now beginning to develop a protocol for doing DNA methylation analysis, where we hope then to use this as a adjunct tool for classification of sarcomas. So I think in future years, this will become another approach that allows us to be more precise in classifying specific types and subtypes of sarcomas and gliomas, and potentially other cancers as well. So to summarize then, what we've talked about this evening are that, first of all, gene alterations are present in many sarcomas that are useful both for classification and also for determining therapeutic approaches. And I hope I've been able to make clear that next generation sequencing is a very good approach for identifying DNA mutations, copy number variations, and especially if you use RNA sequencing, the presence of gene fusion events. And so together, these kinds of technologies allow us to do our best to identify targets and help manage our patients as best we can. So that's basically what I wanted to share with you, and I'd be happy to take any remaining questions.
Thank you, Chris. Thank you very much for your really very nice and experience and really very nice talk. Do you have any question in the audience?
Yes. Do you consider that genotype mutational burden is useful in soft tissue sarcomas?
I'm sorry, what's useful?
TMB in sarcomas.
Mutational burden.
TMB. TMB.
Oh, tumor mutation burden, sorry. In a word, no. I don't think that we've seen very much in the way of mutation burden. We've sequenced quite a number of pleomorphic sarcomas, liposarcomas, and so forth. They do not have high TMBs. So I don't think it's all that helpful.
Chris, do you consider which is the really impact in the pan-cancer publication at the beginning of this year in soft tissue sarcoma or in GIST? Do we have any impact regarding the publication in Nature of pan-cancer?
I'm not sure which paper you're referring to. The
pan-cancer that shows with more details all the atlas of the human tumors. Remember, in the Nature is really a huge number of mutation in solid tumors. They are more precisely to epithelial tumors. But yeah. Do you have any consideration of that?
Yeah, no, I don't think that, I mean, I think it's useful information in the sense that it gives us a better idea of the total number of genes that may play a role in cancers. But in terms of diagnosis or treatment, not so much. That's why, even though, you know, in theory, the best thing that we could do for everybody would be do an exome, sequence the entire exome, but that is quite expensive. And we find by sequencing 225 genes, we can find everything that's important for a patient as compared to an exome. And we've done the comparison many times. And the exome is rarely giving us more information than just the panel sequencing. So biology, yeah, important, but diagnosis and treatment, not so much.
And in terms of the precisely medicine that several years we talk about it, so precision medicine, do you think that you go to the patient, or you go to the tumor of the patient, or you try to establish a platform to hold sarcomas and then you go to the patient? Which is your approach of your lab?
I think I would go to the patient. I think that if we can get more sequencing done on more cases, we will find the rare exceptions that may be treated better than with standard chemotherapy, for example. I know it's expensive. I know that many insurance companies are not interested in spending money on molecular diagnostics. That's still true here in the United States as well as elsewhere. It's not always affordable, but when I give you an example. Yesterday, I was signing out a case. A gentleman has metastatic squamous cell carcinoma of the lung. He already had surgery. He already had chemotherapy. Now he has a lesion in the leg that turns out to be metastatic tumor. And yesterday, I was reporting a MET exon 14 skip, which is highly treatable, has an FDA-approved therapy. Now, if we had sequenced his tumor when he was first diagnosed, he would have already been treated with that drug, and he probably would have had a better response and less side effects. But instead, they did all the standard chemotherapy and waited until, you know, he has advanced disease. And now we have the opportunity to find this rare mutation. So I'm biased, but I like to see more sequencing done sooner than later.
Okay, and how is the behavior of the public health there? Because here we are 4 months in quarantine here because the pandemic. So we are 4 months. We have the economy that is delayed, so the technology is not the best one. So we are really so much problems. I guess for you is easier because you have another type of population that is more academic, and you have to reimburse, and all the university is going to grow with your findings. But for us, it's very difficult. So how you can translate your technology to our country, so to our region? I am not crying, so.
Well, so there are some things that may be more affordable, immunohistochemistry and FISH, for example. If you have a pathologist who is using the pan-Trk antibody, they may be able to find the tumor with very strong staining, and it may be worthwhile trying to treat. And FISH is not that expensive, and many labs are already doing it, so you can expand the number of probes. I think that in the future, we will see a next generation of sequencing. And I think it's going to be much cheaper. Right now, we have a kind of, we only have 2 companies competing in this space, and one of them is dominant. And so the prices came down, and now they're flat, and they're starting to go back up. And they're expensive. I mean, even for us, to run a big panel is, you know, at least $500, $600. But there are companies that are coming forward with newer, cheaper approaches to DNA sequencing. And if we can prove that those work well, then they should bring the cost of the test down to maybe $100 or $200, at which point then I hope to see everybody in the world begin to do more sequencing.
Well, excellent, Chris. Really a very nice talk. It was a pleasure for us. So keep with us, and you know that you perform more than 250 genotyping from us. We worked together during 15 years, so
Right.
I guess it was a privilege. So thank you very much for all the fellows.
My pleasure. And if you have more cases you want to send our way, just let us know. We're happy to help.
Thank you, Chris. Thank you.
Okay.
Bye-bye.
Bye-bye, everybody.
Bye.
Thank you.
Thank you. Bueno, ¿están?
Sí. Justo tenemos un chat. Albano justo preguntó.
Sí, yo quería preguntar también si se usaban firmas moleculares como los
Sí.
ultravioletas, pero bueno.
Yo tenía unas
Sí.
preguntas en cuanto a lo que estuvimos.
Bueno,
No.
Si querés,
No, contestar a Fede si...
lo que hacemos es continuamos y hago un resumen un poco de lo visto. Me parece que es necesario para un poco más allá de realmente son figuras de renombre las tres personas que hemos visto en inglés, pero bueno, también lo podemos rebuscar, pero realmente en el futuro, cuando los residentes pasen los 10 o 15 años, se tienen que acordar de estas charlas, ¿sí? Porque son importantes, porque es la gente que cambia un poco el destino de una patología. Algunos con más y otros con menos recursos, pero realmente cambian el destino de las patologías. Así que yo hago un resumen, básicamente, de lo que son los sarcomas para todos los residentes. Si querés, comparto la pantalla.
Dale.
¿Sí? ¿Ahí estamos?
Ahí se ve bien.
Bueno, traten de tolerar 20 minutos o 25 minutos. Un poco esto es el fruto de ser perseverante en algunos rasgos de la vida. Entonces, todas estas cosas que tienen mi nombre abajo no están abajo mío ni por mucho menos, pero de las cuales me siento partícipe y casi un hacedor de muchas de las cosas que están acá abajo, la mayoría vinculada obviamente a las instituciones donde trabajo, en Fleming hace 27 años, en el Madariaga de Misiones hace 8 años, y después el resto de las instituciones ligadas o de las fundaciones, de las cuales hemos compartido casi todo, es básicamente ni por el apellido, ni por la asociación, ni por nada, es por el estímulo que uno puede tener con determinadas patologías. Y así como melanomas, sarcomas y cáncer de riñón forman parte de la libido de uno, cuando uno escucha estas charlas, básicamente, no tanto de España ni de Francia, que se acercan un poco más a lo clínico, sino de lo molecular, realmente a uno le da una envidia terrible. No solamente no poder acceder, sino tampoco de entender. Así que un poco esos son mensajes que uno tiene que tener. Pero para llegar a eso uno debe hacer las cosas bien. Para hacer las cosas bien, básicamente uno tiene que entender el ABC. Entonces la agenda va a ser breve, voy a tratar de ser muy rápido. Pero tuvimos 3 presentadores realmente bárbaros en el sentido del lustre que le da al curso superior, en tratamiento perioperatorio, en Janif Zelay de pacientes con sarcoma metastásico y a Chris Corles en lo que hace a patología. Pero acuérdense cuando ustedes ven un paciente con un sarcoma, que de 100 pacientes con tumores, 1 es un sarcoma. Dentro de la patología es el 1% en adultos, pero dependiendo el tipo de registro y el país, en los tumores pediátricos refleja entre el 8 y el 15%. En Argentina, si uno traza una media, en base a este gráfico que ven, hasta que la próxima edición de la IARC nos muestre, voy a seguir torturando con lo mismo, sobre los 129.500 casos, en Argentina se estiman más o menos anualmente 1.300 sarcomas. Y si uno cruza una línea media clínica, la edad promedio son los 48 años, tomando los adultos, la mayoría de las extremidades. Como vieron en el gráfico de Blay, los sarcomas no clasificables, los GIST, y los liposarcomas son las 3 histologías más frecuentes. Hoy en día el diagnóstico de un sarcoma, básicamente uno lo tiene que apoyar en la morfología, no depender siempre de la inmunistoquímica, secundariamente y más chico de la inmunistoquímica, y tercero y más chico en molecular, pero lo molecular básicamente en aquellos tumores que ya tienen drivers conocidos. Como bien lo escucharon a Corles, si bien parece ser el futuro, a este costo es inviable. Entonces, salvo que sea un tumor a células redondas, pequeñas, azules, donde hay alguna dificultad técnica en poder decir qué tipo de sarcoma es, en el resto es bastante difícil llevarlo a todos los casos, pero eso no omite la necesidad de conocer que eso existe. Entonces, si vamos a la localización, fíjense, esto es un gráfico complejo, pero esto es de Enzinger en el año 2008, que es uno de los, Enzinger y Weiss es el libro de sarcomas básicamente más importante, y la localización más frecuente, en el 26% de los casos, son las extremidades inferiores, seguido por los sarcomas retroperitoneales. Esos son los 2 sarcomas o las 2 localizaciones más frecuentes. Y tercero, los viscerales, donde ahí están incluidos los sarcomas uterinos y los GIST. Esto es clásicamente el sarcoma típico, un sarcoma de raíz de muslo, que es la localización más frecuente. En Fleming hicimos un trabajo que presentamos en ESMO del 2011, hace 9 años, sobre 3.426 pacientes con sarcomas, de los cuales la localización, obviamente, del miembro inferior era la localización más encontrada, y dentro de los sarcomas, en esto pude hacer el análisis solamente por histologías en 1.016 pacientes. La histología más frecuente eran otras, y dentro de los más comunes, los leio, los GIST y los liposarcomas eran las 3 histologías predominantes. Hasta hace poco tiempo atrás, y si los residentes están en un hospital general, van a ver que el cirujano cuando dice, bueno, le saqué un sarcoma, y parece toda una piedra y todo igual, y hoy en día vemos que no es todo igual, vemos que existen más de 50 subtipos de sarcomas, esta es la nueva clasificación de la GU, y dentro de los 50 subtipos hay más de 62.000 mutaciones encontradas, realmente un número increíble, que no solamente nos sirve para diagnóstico, sino también para la búsqueda de drivers, como hoy escucharon ya las 3 personas que hablaron anteriormente. Pero fíjense, más de 50 tipos histológicos y más de 62.000 mutaciones. ¿El mismo tratamiento para todos los pacientes? Básicamente no. Hoy en día podemos identificar algún subgrupo, nos cuesta, fíjense en adyuvancia lo que presentó Broto, lo que presentó Gianni Pselay también, que dijo que 1 de cada 4 pacientes, uno hace quimioterapia empírica con doxorubicina, pero son un montón de enfermedades puestas en una bolsa. Entonces, ¿cómo definimos a los sarcomas? Todos estos son pacientes de la institución, salvo este sinovio sarcoma pegado al fémur, el resto un sarcoma retroperitoneal, un sarcoma uterino, un angiosarcoma de mama, un sarcoma de cara posterior, un angiosarcoma de cavidad oral, un sarcoma radioinducido en una mujer con cáncer de mama y un sarcoma pleomórfico de codo. Entonces, ¿cómo definimos básicamente los sarcomas? ¿Por el sitio primario? ¿Por la histología? ¿Por la inmunistoquímica? ¿Por el perfil molecular? ¿Por la evolución clínica? ¿O por la sensibilidad a las drogas? O sea que esto es un poco lo que ustedes, más allá de lo preciso que escucharon hoy acerca de los speakers anteriores, ustedes cuando definan un sarcoma, básicamente tienen que pensar en estas 6 situaciones o 6 entidades: sitio, histología, inmunistoquímica, perfil molecular, evolución clínica y respuesta a drogas. Entonces, acá tenemos un leiomiosarcoma de muslo, ¿sí? Y un leiomiosarcoma de retroperitoneo. ¿Ustedes creen que la evolución es la misma? No, completamente distinta, aunque tengan el mismo nombre y apellido. Los leiomiosarcomas de extremidades básicamente recurren en el pulmón, y los leiomiosarcomas del retroperitoneo recurren localmente y recurren en el hígado. O sea que tienen el mismo nombre y apellido, tienen diferentes sitios y tienen una biología y una evolución clínica completamente distinta. Entonces, tratando de buscar en las clasificaciones, esta es la clasificación última, y este es un muy buen artículo que les recomiendo, tiene 10 años pero sigue vigente. Es un artículo muy interesante, donde divide a los sarcomas en 3 grupos. El grupo 1, una histología homogénea y un evento molecular patognomónico conocido. Ejemplo, los GIST, los Ewing, los dermatofibrosarcoma protuberans. El grupo 2 es un grupo de pacientes jóvenes con histologías homogéneas parecidas y un cariotipo complejo, ¿sí? Los cordomas, los sarcomas epitelioides, hoy he encontrado en sarcomas epitelioides algunos puntos moleculares de anclaje. El grupo 3 son pacientes adultos con histologías pleomórficas, ¿sí? Y algunos agarrados a algún dato molecular. Ejemplos, los liposarcomas desdiferenciados o los tumores malignos de la vaina periférica o los mixosarcomas. Y el grupo 4, que es el más frecuente, leiomiosarcoma, osteosarcoma o sarcomas pleomórficos, son adultos, ¿sí? Con cariotipos sumamente complejos y sin eventos moleculares identificables. Este es un muy buen artículo que sintetiza un poco lo que uno ve en la histología y lo que uno ve en lo molecular. Entonces, pero fíjense lo que es esta masa retroperitoneal. Es lógico que histológicamente no sea igual y tenga áreas desdiferenciadas o áreas realmente complejas desde el punto de vista genotípico. Y fíjense al corte de la macroscopía, lo que es. Este es un liposarcoma, un leiomiosarcoma con áreas grasas. Realmente si el patólogo toma una muestra solamente de este sector, histológicamente va a ser claramente distinta al centro de la masa. Otra clasificación de los sarcomas que ustedes tienen que conocer, porque va a entrar en el examen también, son básicamente los L-sarcomas, que si bien lo único que tienen parecido es la L, los leiomiosarcomas y los liposarcomas, y por su frecuencia, pero básicamente no tienen una evolución clínica similar, pero se llaman L-sarcomas. Los T-sarcomas o los T-sarcomas son los sarcomas traslocados, donde hay ya definiciones claras. Ejemplo más común es el Ewing, es el sinoviosarcoma con la traslocación X18. Los sarcomas K, que no son kirchneristas, sino que son los sarcomas que dependen de alguna quinasa, básicamente los GIS, los dermatofibrosarcoma protuberans o el tumor fibroso solitario. Los C-sarcomas, que son los sarcomas con cariotipos complejos, ¿sí? Y los I-sarcomas, que son sarcomas básicamente no clasificados o inclasificables. Esta es otra clasificación no solamente genética ni clínica, sino por los vehículos de oncogénesis. Entonces ya los sarcomas no tienen ese aspecto de roca, uno le debe dar algún signo molecular. Entonces, un poco en relación al tratamiento de una enfermedad localizada que habló Broto, se los voy a sintetizar un poco más. La cirugía sigue siendo el rol fundamental y es el tratamiento que cura a estos pacientes. Fíjense este caso, este es un paciente nuestro que los residentes lo han visto hace poquito, es un sarcoma pleomórfico pegado a la pared torácica y pegado a lo que es el miembro superior derecho. Esta fue la cirugía, esa es la masa necrótica, había recibido radioterapia preoperatoria. Y este es el tipo de cirugía que lamentablemente se siguen haciendo porque son histologías poco sensibles. Recibió quimioterapia, recibió radioterapia, no respondió y el paciente fue a la cirugía. Una cirugía extremadamente cruenta, pero conceptualmente quiero mostrarla como cirugía tal porque esta es la masa tumoral, los márgenes deben ser negativos, aunque haya que hacer resecciones realmente complejas vasculares, los pacientes con sarcomas avanzados localmente o con sarcomas con histologías poco sensibles deben ser sometidos a esta cirugía, si no el tumor termina siendo lo que el cirujano en definitiva después no va a poder hacer. O sea que la cirugía básicamente debe ser resección completa. 1 o 2 centímetros de margen debe ser resección completa y el cirujano no debe ver básicamente el tumor, salvo como en este caso que se ulceró e invadió la piel. Y después, la reparación depende también del tipo de cirujano, pero básicamente amerita colgajos microquirúrgicos o amerita cirujanos muy entrenados en la reconstrucción de partes blandas. Y esta es la macroscopía del tumor definitivamente, donde tiene que estar correctamente rotulada cuando le llega al patólogo, porque podemos hablar muy bien de datos moleculares o de muchas mutaciones, pero básicamente uno debe tener las herramientas necesarias para saber que la macroscopía debe estar bien rotulada, que los márgenes deben estar teñidos eventualmente con tinta china, si es que fue el margen de resección dudoso, porque fíjense que lo que es la pieza es muy difícil hacer tacos de cada uno de los márgenes. Por eso, el margen que establece el patólogo es habitualmente el margen más cercano que vio el cirujano donde hizo la cirugía y lo tiñe un poco con tinta china para hacer un margen para poder evaluar con un poquito más de precisión. Esta es Madame Curie, premio Nobel en 1906 y 1911 por haber identificado al al polonio inicialmente como molécula radiante y después al radium. Radium significa rayo. Y esto es si hacemos radioterapia antes o después. Fíjense que entre los factores pronósticos, al mejor sarcoma, si tomamos sin histología dominante y tomamos por localización, los sarcomas de extremidades son los sarcomas que tienen mejor pronóstico, no así los retroperitoneales y viscerales. Es de sentido común entender que un sarcoma de extremidad básicamente es más fácil de operar que un sarcoma de retroperitoneo y que un sarcoma uterino o que un sarcoma de víscera. En lo que hace sobrevida global de los sarcomas con la cirugía sola, fíjense que biológicamente recurre la mitad de los pacientes, el 50% de los pacientes con sarcomas recurren, y si es un fenómeno biológico o un fenómeno o una falla quirúrgica, la pregunta la hacemos en la mayoría de los modelos tumorales, y acá podemos entender que puede ser una mezcla entre falla quirúrgica y falla biológica, porque los sarcomas son tumores de difícil sospecha clínica inicial. Este es un paciente con un sarcoma en la cara posterior del muslo de 8 centímetros, sin compromiso vascular. Es un sarcoma pleomórfico, sin metástasis pulmonares, y básicamente el estudio que ustedes no deben dejar de hacer es una resonancia para ver la relación con los vasos, la relación con los nervios, para ver la relación con las otras estructuras óseas o vitales, y básicamente hacer una tomografía de tórax, porque en los sarcomas de extremidades el sitio más frecuente de diseminación son los pulmones. Entonces la pregunta siempre es, ¿qué hacemos antes? ¿Hacemos la cirugía seguido de radioterapia? ¿Hacemos radioterapia seguido de cirugía? ¿O hacemos cirugía, quimioterapia con la droga colorada, seguida de radioterapia? ¿O bien hacemos la combinación de quimioterapia, doxorubicina e ifosfamida, como bien mostró Broto, cirugía y después radioterapia o viceversa? Esta pregunta no hay realmente una respuesta firme. En general los sarcomas son la mayoría diagnosticados por arriba de los 5 centímetros, entonces si uno tiene la posibilidad de trabajar en un centro donde la sospecha es alta, hacer una biopsia, hacer la histología y después hacer tratamiento neoadyuvante con 3 ciclos de quimioterapia, combinada básicamente con doxorubicina y ifosfamida, después radioterapia o después la cirugía, sería el esquema ideal. Habló Broto de la quimioterapia adyuvante, no voy a repasar el metaanálisis, que es la evidencia más firme que tenemos sobre 1.500 pacientes, pero lo más interesante, fíjense que es la histología. La histología falta en este metaanálisis en el 18% de los pacientes, es un número muy grande. En el 28% de los pacientes falta el grado. El 37% no tenían tampoco establecido cuál era el tamaño del tumor. Por lo tanto, este metaanálisis, por más que sea el único metaanálisis, tiene muchos datos faltantes. ¿Y qué mostró este metaanálisis en números un poco más redondos de lo que mostró Javier? Básicamente es un beneficio en sobrevida global en sarcoma de extremidades del 7%. En neoadjuvancia, lo mismo que él mencionó, me parece que el esquema ideal es hacer 3 ciclos de doxorubicina e ifosfamida, después la cirugía y después irradiar, o bien hacer radioterapia después de los 3 ciclos de doxorubicina e ifosfamida. Los japoneses mostraron este estudio comparándola contra gemcitabina y docetaxel, y fíjense que en términos de sobrevida libre de progresión resultó ser inferior. Por lo tanto, no hay nada mejor que seguir haciendo antraciclinas y ifosfamida neoadjuvante. En lo que hace la charla de Janit Zuley, tratamiento de enfermedad avanzada, ¿cuáles son los objetivos? Fíjense, los patrones de recurrencia en sarcomas son estos. Metástasis pulmonares, 70% de los sarcomas, metástasis hepáticas, 30%, recurrencias locales, 40%, metástasis óseas, 15%, y metástasis cerebrales, 15% del total global de los pacientes con sarcoma, pero casi un 50% de aquellos pacientes que hacen metástasis pulmonares. ¿Qué es interesante en esto? Es saber cuál es el objetivo. Entonces, ¿cuál es el objetivo? Paliarlo solamente en su enfermedad metastásica, achicar la lesión para poder operar, mejorar la calidad de vida. La segunda pregunta que uno tiene que hacer es ¿cómo se hacen en cáncer de mama? Antes de decidir la primera terapia. ¿Tiene receptores hormonales positivos, sí o no? ¿HER2 positivos, sí o no? En sarcomas tienen que hacer lo mismo. El ejercicio es este. ¿Cuál es el objetivo primario de la intervención? ¿Paliar o llevar al paciente a una cirugía? La segunda pregunta es aseverar si la droga que vamos a hacer es activa o no en sarcomas. En tumores nerviosos de la vaina periférica no hay ninguna droga activa. Uno puede pensar que la ifosfamida más el etopósido puede ser una combinación activa, pero realmente no. O sea que son pacientes que son realmente huérfanos de tratamiento sistémico útil. Entonces, la tercera pregunta es si hay alguna droga específica para esa histología. Y después, obviamente, saber si la cobertura médica la va a cubrir, pero básicamente ustedes en su mecanismo de aprendizaje tienen que saber si hay alguna droga específica para esa histología. La cuarta es si hay algo superior a la doxorubicina en este subgrupo. Y la quinta pregunta, que es saber el nivel de evidencia que tiene la aprobación o ese estudio clínico. Entonces, en los datos históricos y elecciones simplistas es saber si uno da una droga versus varias. ¿Cuál fue la primera droga utilizada en sarcomas? Esta pregunta la hacemos siempre. Y esto fue una publicación del JAMA de 1946, donde Goodman y Gilman, ¿sí?, presentaron este paciente que tenía un linfosarcoma. Fíjense, un linfosarcoma, no sabemos si es un linfoma o si es un sarcoma, básicamente, pero fue uno de los primeros pacientes tratados, ¿sí?, con mostazas nitrogenadas, uno de los primeros agentes quimioterápicos utilizados. En esto no había estudios randomizados, no había nada, solamente se narraba. Y fíjense la peculiaridad que el Alfred Gilman, que es el libro de fármaco que ustedes deberían haber aprendido en la facultad, era un mayor, o sea que trabajaba para las Fuerzas Armadas de Estados Unidos. Entonces se empleaban estas drogas, ¿sí?, no solamente como agentes terapéuticos, sino también como agentes biológicos en la guerra. Este es el paciente con el linfosarcoma, ¿sí?, que fue resistente a la radioterapia inicialmente, y le dieron estas mostazas. El paciente, después del cuarto día de tratamiento, pudo tragar y pudo dormir. O sea que fíjense los criterios de evaluación de calidad de vida. La masa tumoral recurrió después de un mes de tratamiento, el paciente se murió, pero fíjense la respuesta que había tenido después de un mes de tratamiento, y esta es una publicación del JAMA de 1946, casi 74 años atrás. Entonces, ¿qué es lo que uno busca? Y fácilmente, por eso cada vez que estamos en la recorrida con los residentes, empezamos discutiendo de sarcoma y terminamos discutiendo cáncer de mama, de cáncer de tumores de timo, de linfomas o de droga A, droga B. Pero básicamente, ¿qué es lo que ustedes buscan cuando hacen el tratamiento A o el tratamiento B? Tasa de respuesta, duración de esa respuesta y beneficiar a los pacientes en sobrevida global. Eso lo hacemos midiendo a través del AJU del RECIST. Y si tomamos la historia de las antraciclinas, no la voy a contar, pero básicamente el primer estudio, ¿sí?, fue dado por uno de los padres de quimioterapia y sarcomas, que es Robert Benjamin, que está en actividad todavía en el MD Anderson. Fíjense, una publicación de la década de 70, la tasa de respuesta, que se sigue sosteniendo hasta la fecha. De 1972 hasta el 2020, la doxorubicina como agente único, la tasa de respuesta es entre el 15 y 30%. El tiempo a la progresión entre los 4 y los 10 meses, y la sobrevida global entre 1 y 2 años, con la toxicidad que ustedes ya conocen. La primera publicación en primera línea con la droga, realmente en sarcomas, mostró en 39 pacientes 33% de respuesta, y si restábamos las histologías sensibles era 20%. El primer combo dado por Jeffrey Gottlieb en el MD Anderson, en el 72 con la doxo y la dacarbazina, tasa de respuesta 47%. Y fíjense la supervivencia global, eran pacientes con sarcomas, y la sobrevida global 10 meses versus 6, sin diferencias estadísticas, porque ahí las estadísticas realmente todavía no corrían demasiado. En los 80, Janis Bray lo mencionó, el Cibadic, un régimen de poliquimioterapia, se lograba un 50% de respuestas, y ahí aparece la tasa de remisión completa del 17%, pero era poliquimioterapia. Acá está marcado en rojo la dosis de la doxorubicina, el Cibadic. Y en los 90 se utilizó el MEI, un esquema básicamente del Dana-Farber, con una dosis un poco más alta de la doxorubicina y ya combinándola con la ifosfamida a una dosis baja, con tasa de respuesta del 50% y remisión completa del 10%. Con la aparición del MESNA y con la aparición de los factores, permitió el escalamiento de las drogas, y así como escalábamos las drogas, escalaba también la chance de responder. Estos son los estudios de fase 3 de agentes únicos contra el combo. Yo nada más quiero que miren esto, si hay alguien todavía atrás de la pantalla. Tomás, ¿me lo podrás aclarar sí o no? ¿Hay gente? Supongo que sí. Básicamente la sobrevida global es 1 año, aunque hagamos combo o aunque hagamos secuencia de drogas. Este es el estudio que mostró Javier Broto, donde fíjense que la sobrevida promedio a 1 año es del 50% con la monodroga versus 60% con la combinación, y la sobrevida libre de progresión realmente muy baja con la doxorubicina monodroga, 5 meses versus 7.4 meses con el combo. Así que la sobrevida global, aún con estudios modernos, ronda el año. Metaanálisis, realmente exactamente igual a hacer una droga versus el combo. Entonces, es muy difícil entender que en sarcomas esta misma remera colorada le queda bien a esta histología a esta histología o bien a histologías más pequeñas. O sea que realmente es muy difícil de tragar que darle la misma droga y ser simplista, uno puede obtener el mismo resultado. Hubo elecciones más sofisticadas en estos años que se trataron de comparar gemcitabina y docetaxel y otras combinaciones contra la reina colorada. Esto es muy, muy interesante. La prueba de concepto que 1 es igual a 0, o sea que dar una droga no sirve para nada, y en esto es el gemcitabina, un fase 2, donde fíjense la lectura acá abajo, el gemcitabina tiene actividad mínima en sarcoma de partes blandas, la tasa de respuesta fue 0. Y dado el docetaxel contra la doxorubicina en un estudio en primera línea, es un estudio fase 2 randomizado, docetaxel versus doxorubicina, el docetaxel fue una droga inactiva, no hubo ninguna respuesta a docetaxel. Entonces, si una droga no servía para nada, ¿cómo pensaron que la combinación de las dos podían llegar a esto, que la prueba de concepto es 1 más 1 igual a 3? Porque el SARC diseñó este estudio, gemcitabina más docetaxel, la tasa de respuesta en la población global fue el 17%. Es un estudio fase 2 y en segunda línea, con lo cual no es el 17% que estimula, sino que fíjense la sobrevida global en esta población mucho más moderna, en segunda línea, fue de casi 18 meses. Y ahí apareció el estudio que también mencionó Broto, gemcitabina versus docetaxel gemcitabina en primera línea. Los datos muy similares en sobrevida libre de progresión y muy similares en sobrevida global. Realmente muy parecido, con lo cual apoya si uno quiere hacer gemcitabina y docetaxel versus doxorubicina, pero básicamente se va a topar con la toxicidad. Hacer doxorubicina es menos tóxico que hacer docetaxel gemcitabina. Aparecieron nuevas combinaciones, esto me parece interesante que lo vean, porque hay análogos de la ifosfamida tratando de mejorar. Son análogos de la ifosfamida sin toxicidad ni urinaria y menos toxicidad hematológica. Esta combinación de doxorubicina versus doxorubicina más evofosfamida mostró esto. Tasa de respuesta 28% para la doxorubicina y 6 meses de tiempo a la progresión contra la combinación menos eficaz en tasa de respuesta, igual sobrevida libre de enfermedad, y la sobrevida global exactamente para las dos ramas igual, 18 y 19 meses. Lo único que muestran estos estudios más modernos es que la hiperselección de pacientes nos lleva casi a 2 años de sobrevida global. Y así, como está este esquema, la palifosfamida, otra droga muy similar, fíjense, casi 443 pacientes, tratándola de comparar contra la doxorubicina exactamente 5 o 6 meses sobrevida libre de enfermedad y 16 meses sobrevida global. Todo muy, pero muy similar. Otro estudio con un análogo de la doxorubicina, que es la aldoxorubicina, una droga muy interesante porque tiene menos cardiotoxicidad, se comparó en primera línea en estudio fase 2 randomizado, donde fíjense que el tiempo a la progresión fue 2.7 meses para la doxorubicina y la mayoría eran leiomyosarcomas, como señala acá la demografía de los 140 pacientes, y se vio con la aldoxorubicina un tiempo a la progresión de 5.6 meses con 25% de respuesta. Sin embargo, la sobrevida global para las dos ramas fue exactamente igual. Y la droga es más costosa y obviamente no es costo efectiva. Estos son estudios modernos en lo que hace a sarcomas, tratando de compararlos con la reina colorada, que es la doxorubicina. Si vemos un estudio contra la trabectidina en histologías diversas, vemos en primera línea también exactamente lo mismo, más tasa de respuesta para la trabectidina, pero sin diferencias en sobrevida global. Exactamente lo mismo hacer trabectidina que doxorubicina en una población general. Entonces, lamentablemente, este ojo de cabra negativo muestra que no hay ninguna evidencia a la fecha, salvo, ahora como vamos a mencionar, los esquemas de poliquimioterapia, en qué pacientes uno eventualmente puede hacer. Pero yo quiero mostrar esto que es sumamente interesante para que vean cómo se desafía continuamente una ley de aprobación de medicamentos. Y este fue un gran cachetazo presentado primariamente en las revistas y secundariamente en ASCO del año pasado. Este cachetazo fue al diseño de los estudios clínicos y se le agarraron con sarcoma, donde básicamente hay poco empírico general y de lo poco que hay lo tiraron abajo. El olaratumab es un inhibidor del PDGFR, básicamente impide la dimerización. Esto fue presentado por William Tapp en un estudio fase 1, fase 2, donde era comparado el olaratumab más la doxorubicina contra la doxorubicina. Y mostró en este estudio una diferencia en tasa de respuesta a la combinación 18% contra 7%. Era un estudio fase 2 randomizado con 133 pacientes. Fíjense las histologías diversas, leio, pleomórficos, lipo. Pero básicamente lo que mostró este estudio, tiempo a la progresión exactamente muy similar para mí, es una diferencia clínicamente no significativa, 6 meses contra 4, pero lo que mostró este estudio fue la diferencia en sobrevida global. Un estudio fase 1-2 mostró una diferencia de 12 meses entre tratar a los pacientes con la combinación de este anticuerpo monoclonal, el olaratumab más la doxorubicina, respecto a la doxorubicina. Con estos datos se aprobó la droga, se aprobó la combinación en primera línea. Y Eli Lilly, que era la compañía farmacéutica, tuvo aprobado en el mercado durante casi 8 meses la combinación en Estados Unidos del olaratumab más la doxorubicina. Hasta que el estudio fase 3, fíjense, esto fue en el 2016, donde esta gente de Eli Lilly, en octubre del 19, estaba muy contentos, ¿sí? Porque este estudio había demostrado esta diferencia en sobrevida global que les mostré de 12 meses entre hacer la combinación respecto a hacer la monodroga. Pero ¿qué pasó? Cuando apareció el estudio fase 3 con más pacientes, presentaron un press release, o sea, mandaron un informe antes de demostrar el estudio, que el estudio fase 3 no había encontrado su objetivo primario, que era la sobrevida global, en toda la población. Ni en toda la población, ni en aquellos pacientes que tenían leiomyosarcomas, que era la población supuestamente más sensible. Entonces, lo que subrayé acá abajo dice, Lilly estaba sorprendido y muy disgustado que el olaratumab no haya mejorado la sobrevida global para los pacientes. Ni contarle las compañías que pagaron esos 6 meses en los pacientes, porque el costo, y se presentó en ASCO, y fue un cachetazo enorme, se presentó en plenaria de ASCO del año pasado, donde fue un cachetazo enorme al diseño de los estudios, básicamente, y a la aprobación de drogas en forma acelerada. Entonces, lamentablemente, el olaratumab quedó en la historia. Eventualmente, aquellos pacientes que tienen por inmunistoquímica, el PDGFR alterado o sobreexpresado o amplificado, eventualmente en un futuro probablemente tendrá alguna chance con estas drogas. Pero fue un cachetazo porque fue el estudio fase 3 en los últimos 15 años que demostró un beneficio en algo en esta patología que son los sarcomas. ¿Qué pasa en segunda línea y más allá, que no fue tocado el tema hoy? Este es el menú del tratamiento del cáncer, o sea, para ser oncólogo, si ustedes quieren, teniendo este menú, yo después le paso la diapositiva, son oncólogos, pero lamentablemente hay que tener algo de artesanía para poder pensar un poco más allá del menú de opciones terapéuticas, y ustedes son más que prescriptores, son personas importantes en el diseño de la estrategia de lo que va a ser un paciente y obviamente en lo que uno puede hacer también desde la sociedad científica o de los estudios clínicos. Estas son las drogas útiles, sacando las anteriores que no sirven, estas son las drogas útiles en sarcomas. Entonces, ¿qué hay por detrás de la escena de la doxorubicina? Y la ifosfamida, gemcitabina y docetaxel, gemcitabina y la carbacina, para los leiomyosarcomas es una buena combinación, el pazopanib, la trabectedina, la eribulina o la dacarbacina monodroga. Eso es lo que hay en líneas posteriores a la droga colorada. Entonces, ¿cómo lo pensamos en sobrevida libre de progresión? Y a veces es muy difícil, porque si la primera línea brindó 6 meses, la ifosfamida como segunda línea son 4 meses, y después tenemos gemcitabina, docetaxel, trabectedina, pazopanib, eribulina, dacarbacina. ¿Y cuál es la evidencia para apoyarnos en estas drogas? Fíjense la secuencia de los estudios. Este es el PALET, o sea, pazopanib contra placebo, presentado y aprobado en el 2012, 8 años. Era un estudio fase 3, la sobrevida en segunda línea fue de 12 meses para pazopanib contra 10.7 del placebo. Sin embargo, esta droga fue aprobada básicamente por esta diferencia de 3 meses en términos de sobrevida libre de progresión, pero fíjense acá que era contra placebo. A pesar de esto, fue una de las aprobaciones más recientes que tenemos en sarcomas en estudios randomizados. 2014 fue esto que yo les mostré, el estudio de Leortici, que estudios combinados, fue negativo, era doxo más ifosfamida, el Picasso 3, también otro estudio tratando de combinar con otro alquilante, fue negativo. Y en el 2016 recién se presentaron los estudios en segunda línea, publicados y presentados 4 años atrás, dacarbacina contra trabectedina, eribulina contra dacarbacina, y en el 2017 las drogas que le mencioné previamente, que fueron básicamente negativas. Dejé los estudios claramente positivos, pero ustedes tienen que saber algo. ¿Cuándo una droga se considera útil en segunda línea? Cuando más del 30% de los pacientes sigue en tratamiento y libre de progresión a 3 meses de haber empezado. Con esa primera premisa, un estudio fase 2 puede pasar a un estudio fase 3. Si el número no se cumple, y esto está dado en base a dos grandes estudios que publicaron, fíjense acá está Janib Zuley, que antes escucharon, el segundo punto es que a 6 meses tiene que haber por lo menos un 15% libre de progresión. Esos son criterios para seguir adelante con estudios, con pacientes en estudios fase 2 fase 3 en segunda línea. Entonces, ¿qué necesitamos del paciente? Obviamente que responda de forma completa, parcial o estable, eso lo llamamos beneficio clínico, y que eso se sostenga a lo largo del tiempo. La trabectedina, una alga marina sacada del Caribe, es una droga española, de ahí creció mucho el grupo español, el grupo del GACE, creció mucho después de la aprobación de la trabectedina en sarcomas, en base a un estudio en segunda línea, comparada con la trabectedina, que si bien es cierto que el objetivo primario era la sobrevida global, el objetivo secundario era la sobrevida libre de progresión. Este estudio mostró básicamente beneficio de 3 meses en sobrevida libre de progresión, no así en sobrevida global. Aún con ese endpoint, en Europa fue aprobada por ser también la primera droga española aprobada para el tratamiento del cáncer. Esta droga en Estados Unidos no fue aprobada, como pasa con todas las drogas europeas. El oxaliplatino fue el primero, la trabectedina fue la segunda. Como pasa en Estados Unidos, la FDA no aprueba las cosas hasta que no tiene una evidencia propia o si no hay evidencia de beneficio en sobrevida global. Entonces fíjense que el beneficio en sobrevida global no existió. Pero es interesante el número que uno ve 12 meses de sobrevida global en segunda línea. La otra droga interesante, muy interesante, que es la eribulina, de poca indicación en nuestro medio, si bien ha sido aprobada en marzo del 2020 para Argentina, es una droga ya aprobada en el 2016 en Japón y también por la FDA. Fíjense que básicamente es un compuesto natural que viene de una esponja marina. El NCI estudió más de 60 líneas, en 60 líneas celulares, tumorales, de eribulina, y demostró actividad. Es un agente antimicrotúbulos de una acción muy peculiar, que obviamente era imposible tratar pacientes con sarcomas o con cáncer de mama, que es la otra aprobación, porque se necesitaba una tonelada de esponja para hacer nada más que 300 miligramos de esta esponja. Hasta que en Harvard sintetizaron la molécula en forma química, y de ahí en más la eribulina apareció en los estudios, y básicamente tanto en cáncer de mama como en sarcoma fue las líneas iniciales celulares en las cuales demostró eficacia, y fue básicamente las aprobaciones. Y estos son los estudios clínicos de la eribulina en sarcoma, fíjense, de poca cantidad de pacientes, donde no hay respuestas parciales, casi 2, 3%, 4%, la mayoría hace estabilidad de enfermedad, y en base a eso se diseñaron estos estudios. Este es el estudio fase 3 que le dio la aprobación a la eribulina, dado exclusivamente para los lipo o los leiomyosarcomas, ¿sí? Porque eran básicamente las histologías que más respondían. Se hace en forma intravenosa día 1 y 8 y contra la carbamazepina. Y el objetivo primario fue supervivencia global. Es interesante, a diferencia de lo que vimos antes, que la trabectina demostró beneficio en sobrevida libre de enfermedad, no así en sobrevida global, y en este caso la eribulina muestra beneficio, fíjense, en sobrevida global, 13.5 meses contra 11.5, una diferencia estadísticamente significativa, no así la sobrevida libre de progresión. Entonces, es bastante difícil entender cómo puede ser que una droga genere beneficio en sobrevida global sin generar ni tasa de respuesta, porque fue 4%, bajísima en todos los subgrupos, pero sí beneficia en sobrevida global. Entonces, le encontraron la explicación a esto. Básicamente, la eribulina parece remodelar la estructura vascular del sarcoma, de las metástasis, y así favorecer que los pacientes hagan más línea de tratamiento posterior. O sea que no sería el impacto de la eribulina per se antitumoral, sino que condiciona las respuestas a los tratamientos que vienen por detrás de la eribulina. Entonces, la toxicidad básicamente es mielosupresión, cansancio, y tienen algo de neuropatía. Esta es la comparación de los 3 estudios que básicamente le dieron la aprobación a estas 3 drogas en segundas o terceras líneas, el pazopanib, la trabectedina y la eribulina. Si hoy uno tuviese que decir, el pazopanib se puede dar en sarcomas no adipocíticos, o sea, no liposarcomas. La trabectedina, mejor que sea un liposarcoma mixoide, y porque va a tener más respuesta, o bien un leiomyosarcoma, y la eribulina es probablemente una droga más activa en los liposarcomas, para lo cual fue aprobada en el mundo. En Japón fue aprobada para todos los sarcomas, en el resto del mundo para los liposarcomas, en Argentina también para los liposarcomas. Entonces, Básicamente esto se habló hoy en día mucho, y ya estamos casi 3 horas de haber empezado. Uno puede entender que los sarcomas son más que piedras, lo mostraron los GIST, básicamente con la mutación del kit. Esto lo mostró, fue tapa de la revista Time, donde realmente con la prueba solamente en un solo paciente de ver respuesta, este fue el primer paciente tratado con imatinib, donde esto ya lleva 19 años, ahí nos muestra la vejez de cada uno de nosotros, fue una alerta en el New England Journal of Medicine, porque antes los GIST estaban dentro de una bolsa de gatos que eran los leiomyosarcomas digestivos, o sea que no había demasiada vuelta y entraban dentro de los mismos estudios. Si quieren les puedo mostrar todos los datos que hay acerca de dacarbazina o doxorubicina en los pacientes con GIST, donde la tasa de respuesta era cercana a 0. Entonces el imatinib bloquea el bolsillo o el dominio intracelular a esa dosis 400 en la mayoría de los GIST que tienen la mutación del exón 11, a diferencia, como bien explicó Corles, que darle 800 miligramos sirve porque en realidad el dominio es más cercano al dominio transmembrana y se necesita más cantidad de droga porque no tiene la penetrancia intracelular. Pero básicamente, fíjense lo que mostró también Janis Bray, que esto es una prueba de concepto. Estos tumores que son las tenosinovitis vellonoduales pigmentarias, realmente con respuestas a fármacos que tienen target inmunológico, o por lo menos estos macrófagos asociados a los tumores. Miren las respuestas de tumores que ni siquiera son malignos. La incidencia de metástasis es rarísima, mencionó 1%, pero habría que ver si ese paciente realmente tenía una tenosinovitis vellonodular pigmentada. Hoy en día estas drogas están aprobadas, pero si no la tienen, el imatinib o el nilotinib también es una buena droga para paliar el síntoma local. Este es el ejemplo que había mostrado en la presentación de ASCO de ya hace 3 años atrás. Y después puede haber tratamientos a la carta en base a poca evidencia: angiosarcoma muy sensible al paclitaxel, bevacizumab, sorafenib; el dermatofibrosarcoma protuberans, un tumor sensible realmente al imatinib; el hemangiopericitoma, o también llamado tumor fibroso solitario, el bevacizumab temozolomide, hoy en día también sensible al pazopanib; el cordoma, también una histología sensible al imatinib; y el sarcoma alveolar, un sarcoma infrecuente, raro, más cercano a la juventud, pero muy sensible al sunitinib y a una droga nueva que es el cediranib. Entonces fíjense lo que muestran, ¿sí? Si bien el nivel de evidencia, la categoría de evidencia que pone el NCCN es baja, ¿sí? Es 2B, en realidad no es con una evidencia randomizada, pero bueno, pero son histologías sensibles. Estos son los sarcomas alveolares. Fíjense la evidencia, qué poca gente fue incluida en los estudios, porque obviamente son histologías complejas, pero con sensibilidad utilizando los criterios RECIST. El crisotinib en los tumores miofibroblásticos, como bien mencionó Janis Blay; el liposarcoma bien diferenciado que expresa amplificación del CDK4 y 6, se beneficia con tanto palbo, ribo o abemaciclib. Otras histologías a la carta: el sinoviosarcoma con el Ewing-Pinet, básicamente la combinación de BAC y E; el fibrosarcoma con la doxorubicina; tumores de la vaina, hay alguna evidencia que los inhibidores de RAF y los mTOR podrían tener algo de actividad; y los liposarcomas mixoides, básicamente con travectidina. Entonces, fíjense que uno puede hacer a la carta estos regímenes. Realmente el advenimiento del NTRK es otro puntito interesante. Y antes de pasar a eso, que van a ser los últimos minutos, mencionar, y esto está publicado en el New England Journal of Medicine de unos años atrás, hace 2 años, fíjense que en la neurofibromatosis tipo 1, una enfermedad realmente muy demoledora para los chicos, básicamente, en 24 pacientes le dieron un inhibidor, como mencionaron antes, de la vía de la MAP quinasa, y la tasa de respuesta fue del 71%. Hace poquito, con Martín Ángel, que estaba ahí sentado todavía hasta hace un rato, pedimos medicación similar para entidades muy parecidas, que son las neurofibromatosis con transformación a sarcomas o tumores del nervio de la vaina periférica, y no le dan ninguno de los inhibidores de MEK dentro de las regulatorias. Pero ¿cómo vamos a hacer estudios clínicos fase 3 en patologías tan raras? Realmente por eso el diseño es muy difícil en esta patología. ¿Qué hicieron cuando no encontraban tasa de respuesta, como por ejemplo en los tumores, en los tumores fibrosos solitarios? Cambiaron las reglas, básicamente. Si uno no puede achicar los tumores, cambia las reglas. Fíjate si el cambio o la modificación de la densidad induce algún beneficio clínico. Entonces lo que hicieron fue, Choi, que es una radióloga del Anderson, que le intenté contactar para el curso superior, se la prometo para algunas próximas charlas estará. Lo que vio es que cambio en la densidad y disminución del tamaño puede ser sinónimo de respuesta. Entonces, en el MD Anderson establecieron que el temozolomide y bevacizumab induce respuestas por criterios Choi en muchos pacientes con estas histologías infrecuentes como tumores fibrosos solitarios. Entonces, debilidades y ventanas de oportunidades de los estudios en sarcoma. Realmente los objetivos son muy difíciles, la población es muy heterogénea, los subgrupos son múltiples. Entonces, realmente encontrar el beneficio en sobrevida global, en sobrevida libre de progresión, ver si buscamos el NGS o buscar una secuenciación para cada uno, es realmente muy difícil. Me parece que la mejor forma es compartir y discutir a los pacientes en un ambiente multidisciplinario, como pueden ser las reuniones grupales de distintos grupos cooperativos, la misma sociedad científica, o CELNET, que es el grupo que armamos entre Europa y Latinoamérica. Guías de tratamiento, y me parece que vamos a dejar, no sé, Tomás, si te parece, la presentación de GIS para la próxima, para, aunque sea tener los datos en enfermedad avanzada y en adjuvancia, de cómo tratar pacientes con sarcomas avanzados. Ustedes preguntarse los puntitos que tocamos inicialmente, pero si uno lo lleva a determinados ítems: performance, edad, historia médica, histología, volumen tumoral, número de metástasis, sitios de las metástasis, tratamientos realizados, acceso a estudios clínicos. Me parece que tiene que ser la primera pregunta, hacer estudios clínicos, y después pensar en medicina translacional. Ver estos libros que son fantásticos para la gente que le gusta sarcomas, y esto es la guía que estimulamos antes. Hay elecciones simplistas, realmente si vamos a las guías es muy fácil dar doxorubicina. Alguna elección más sofisticada, que tampoco es tan sofisticada, porque docetaxel, gemcitabine o adriaifo no es tan sofisticado. Y creo que las elecciones más sofisticadas es buscar la histología y tratar de que a cada paciente le aprueben lo que está evidenciado en esto. Las guías estas las tienen todos, me parece que no tiene demasiado sentido, pero fíjense, esto es muy parecido, en las guías de la Asociación Argentina de Oncología también lo hemos hecho, si quieren pueden mirarlas, es muy similar a lo que está escrito en las guías internacionales, donde si uno tiene un sarcoma pleomórfico, básicamente va a ir por las guías convencionales. Si uno ve una histología muy particular, puede ir a cada una de las histologías y cada una de las drogas específicas. Estas son las guías nacionales. Esta es la última guía que hicimos en la Asociación de Oncología, con cada una de las disquisiciones acerca del tipo de histología y tipo de beneficio con la droga. Me parece que los combos, o sea, hacer combinación de quimioterapia, es exclusivamente para pacientes en buena condición clínica, en aquellos pacientes que ustedes consideran que si le achicamos el tumor, eventualmente lo podemos operar, y en aquellos pacientes que tienen histologías sensibles a la droga que le podamos dar. Y en aquellos pacientes que tengan tanto volumen de enfermedad que estén sintomáticos y que uno, si tiene un synovial sarcoma, le pueda dar combinación para llevarlo a remisión. Este Renatus cartesius es solamente Descartes, que simplemente el método científico es sencillo, simple, pero a veces simplificarlo hace que uno deje pasar histologías muy sensibles como los sarcomas de Ewing, identificando otras patologías que no hay tratamientos y para otras histologías realmente sí. Entonces, ojo con esto. Realmente traten de hacerse la pregunta: ¿qué histología tiene? ¿Qué es lo que el paciente puede recibir? ¿Y en qué contexto está? Secuencias de agentes únicos: hacer doxorubicina primero, ifosfamida, dacarbazina, docetaxel, gemcitabine, después pasar a trabectina, eventualmente para pacientes que están en performance malo, que no tienen síntomas y tienen múltiples lesiones pulmonares que nunca van a poder acceder a cirugía, o que tienen múltiples comorbilidades. En estos pacientes sí, ser simplista y dar solamente doxorubicina. Esta es una de las últimas diapositivas, que este es un estudio presentado hace unos años atrás, donde cuántos pacientes hacían primera línea en sarcoma, 99%, cuántos pacientes hacían 2 líneas, 24%, y más allá de las 2 líneas, 8%. Y con todas las drogas modernas, si le podemos llamar modernas, la sobrevida global en una comunidad general en Alemania era más o menos de 2 años. Bueno, estos son 4 o 5 slides más que quiero mostrarles lo difícil que es habitualmente ver estos tumores. Este es un paciente nuestro también de la práctica cotidiana con tumor nervioso de la vaina, sintomático, progresado en múltiples cirugías, radiación. Y sí, a pesar de que uno decía que son quimioresistentes, hizo doxorubicina y ifosfamida por 4 ciclos y estuvo 4 años con remisión completa. O sea que a priori yo no daba 2 mangos por la respuesta. Y realmente, era realmente, generaba mucho temor darle la combinación por la cantidad de cirugías, lesión torácica, y accedió a remisión completa y le duró 4 años. Por eso a priori uno cree que el beneficio en una histología que está escrita, que es resistente, realmente la prueba clínica es que no. Fíjense, este paciente con 3 líneas de quimioterapia previa, le di eribulina bajo un estudio clínico. En ese estudio clínico participé, eribulina contra dacarbazina. Estuvo 19 meses con respuesta a la eribulina, que tampoco era inesperado. Esta mujer que estuvo casi 10 años con crecimiento, tenía un leiomyosarcoma, falleció hace 3 o 4 meses en la Sala de Internación General en Fleming, una mujer con un sinovio sarcoma de miembro inferior, y llevaba 10 años de enfermedad avanzada, y obviamente no queríamos hacer quimioterapia, ni ella ni yo, así que estuvo 10 años sin síntomas y sin progresión de su enfermedad. Los liposarcomas con recurrencias locorregionales son realmente un problema, y la cirugía tiene rol siempre y cuando el cirujano esté entrenado en operar liposarcomas. Significa poder disecar la grasa del retroperitoneo entera, ¿sí? O sea, ese es el único rol de la cirugía en lo que son los liposarcomas. Este es un condrosarcoma de partes blandas de pared torácica visto hace poco, con muy buena sensibilidad a la doxorubicina. Este es otro paciente con un leiomiosarcoma de pared intestinal, no GIST, que tampoco respondió a nada. Entonces, para terminar con 4 o 5 diapositivas, para que vean que son enfermedades muy difíciles, muy complejas, y los datos no nos acompañan. Esto es fibromatosis agresiva en una zona del plexo braquial en una mujer relativamente joven, donde lo único que apareció reciente es el sorafenib contra placebo, con tasa de respuesta del 35%. Acuérdense que el sorafenib en fibromatosis se da habitualmente a la mitad de la dosis, que son 400 miligramos. Pero tenemos estas opciones: vigilancia, cirugía, radioterapia, antiinflamatorios, hormonoterapia. Sarcomas uterinos, hay distintas citologías. No es lo mismo tratar un carcinosarcoma, que es parecido más a un tumor epitelial que a un sarcoma, como a los leiomiosarcomas o como a los sarcomas del estroma endometrial, que de bajo grado son una histología y de alto grado son otra histología. Entonces, otra fibromatosis agresiva pegada a una prótesis mamaria. Los angiosarcomas, la epidemiología, la localización, vinculado al Kaposi, vinculados al scalp, sí son más sensibles a los taxanos, pero realmente la evidencia clínica no es como en cáncer de mama. Dermatofibrosarcoma, tumor fibroso solitario, rapto del adulto son iguales a los sarcomas pleomórficos. Osteosarcoma extraóseo, muy parecido a los sarcomas óseos. Hemangiendoteleomas epiteleoides, muy parecidos a los angiosarcomas. Pecomas, sarcomas epiteleoides, sarcomas alveolares. Muchas histologías, todas en la misma bolsa. Y para terminar, si bien lo presentó Janet Blake y también Corles presentó el ENTRAC en sarcomas, que es muy interesante, pero esto es para que ustedes le den nivel de prioridad. No hay que pedirle a todos el ENTRAC. Básicamente, sí pedirlo en aquellos pacientes que tienen sarcomas infantiles o fibrosarcomas infantiles, porque la gran mayoría son ENTRAC positivo y se benefician con el tratamiento, o bien los GIST wild type. Esos pacientes tienen indicación de buscar por inmunistoquímica inicialmente y después buscar la fusión por FISH o por NGS. Pero pues el resto de los sarcomas que tienen una mutación determinada no le piden ENTRAC porque no la van a encontrar. Entonces, como conclusiones, creo que tienen que tener en claro que son enfermedades diversas y son huérfanas de órganos, porque pueden incluir a cualquiera de los órganos que existen en la economía. Son sumamente heterogéneas aún dentro del mismo subtipo histológico, son realmente apasionantes. La histología y los conductores descubiertos son los biomarcadores, no tenemos que andar buscando en PDL1 o el TMB, y creo que el futuro, en este caso, depende de nosotros, básicamente de tener más investigación clínica y de generar más grupos cooperativos. El lente es una puerta abierta, y me parece que esta es la última diapositiva. Y fíjense, no les voy a dar hoy GIST, lo vamos a dejar para la próxima charla, pero básicamente esta fue una reunión, la primera reunión de GIST, donde, es más, Janis Blake ya estaba montado dentro de lo que son los líderes de opinión en sarcomas, y esto pasaron 19 años. Yo había terminado la residencia hacía 4 años y había viajado a la primera reunión de GIST en el 2001 con uno de mis residentes egresados, que es Gustavo Yankelevich, que fue mano derecha del superintendente de la salud hace escaso tiempo atrás, y en el medio está Enrique Roca, que a diferencia de lo que la gente cree, en el mundo los GIST están tratados por los oncólogos que ven sarcoma, no los que ven tumores digestivos. En ese caso, en el 2001, hace 19 años atrás, viajamos juntos a Helsinki y pudimos discutir por lo menos los primeros datos que había en esta patología tan apasionante como los sarcomas y los GIST. Así que con eso me parece que terminamos por hoy.
Muchas gracias, Matías. Vamos a hacer algunas de las preguntas que el público vino dejando. Albano pregunta sobre tu opinión respecto a la radioterapia neoadjuvante y sobre el rol de la secuenciación en sarcoma, y si en Argentina podría haber algún tipo de posibilidad de tener más accesibilidad a la misma y a estudios translacionales.
Bueno, primero quiero saludarlos porque tenemos un overall survival, más o menos hay 47 de los iniciales 60, con lo cual es un buen número. Así que eso es, primero felicitarlos que aguantan todavía 8 y 5, escuchar hablar de sarcomas es importante. Respecto a la neoadjuvancia, creo que si uno trabaja en un centro donde la sospecha clínica de sarcoma está y uno puede ver primariamente al paciente con el sarcoma si tiene más de 5 centímetros respecto a la fascia, independientemente de la histología, me parece lo más atractivo hacer neoadjuvancia con la combinación, no hacer guiada por la histología, hacer doxorubicina más ifosfamida, que es nuestro régimen habitual, la doxorubicina en infusión continua, hacer en 3 días, más la ifosfamida 10 gramos metro, creo que es la mejor opción. No es la mejor opción porque vamos a obtener mayor beneficio en resecabilidad, porque eso está demostrado que no, ni en tiempo a la progresión, y tampoco lo sé si en sobrevida global. Creo que no. Pero lo que eventualmente le vamos a evitar al paciente es hacer algo postoperatorio sin tener una vara. Me parece que el paciente que tiene mejoría clínica, el tumor se ablanda, uno lo ve, lo palpa después de cada ciclo y tiene algo de reducción, me parece que podemos determinar in vivo la sensibilidad al tratamiento y además hacemos cierta cronoterapia con 2 o 3 meses de quimioterapia antes de decidir la cirugía. La escuela del MD Anderson, básicamente la cual yo me apoyo mucho, hacían habitualmente 3 o 4 ciclos de quimioterapia, después radioterapia y después la cirugía. Esa es la secuencia habitual. Pero creo que uno paliaría la metástasis a distancia, o por lo menos evitaría desde el punto de vista racional, haciendo al menos 3 ciclos de quimioterapia. El estudio de Gronchi, no este que presentó guiado por la histología, sino uno anterior que hacía 3 ciclos de quimioterapia, cirugía, versus 3 ciclos de quimioterapia, cirugía y 2 ciclos de quimioterapia, dan el apoyo para poder hacer 3 ciclos de medicación, y dependiendo obviamente de las comorbilidades, pero básicamente creo que es probar quimiosensibilidad en vivo y realmente es la mejor opción en centros que vean sarcomas. NGS hay un trabajo de ASCO presentado el año pasado, donde parecía, y también una discusión con Deitois, que es uno de los patólogos de referencia en Europa que participa con nosotros en el grupo cooperativo Celnet, donde dijo que de toda la cantidad de pacientes con sarcoma que habían accedido a la plataforma NGS, si él veía que alguno de sus residentes o médicos de staff indicaba un NGS en sarcoma, le cortaba las manos, porque lo único que cambió fue el 8% en cambio en la histología. Pero la mayoría de las histologías en las cuales hubo confusión fue en leiomiosarcomas, en liposarcomas y en sarcomas pleomórficos. Entonces él consideraba que si un patólogo entrenado por él no podía distinguir un liposarcoma de un leiomiosarcoma, realmente no tiene ningún sentido. Entonces me parece que NGS como diagnóstico la respuesta es no, no debería hacerse. Los patólogos deberían aprender a mirar a los sarcomas. Si uno lo hace en el contexto de una investigación clínica, me parece que es bienvenido. Si uno lo hace en un paciente que progresiona a primera línea y busca un driver, me parece que, entre comillas, bienvenido si lo puede pagar. Y me parece que la respuesta que tuvimos de Corles última, si es que lo escucharon los chicos, básicamente es, en cuanto haya más competencia y básicamente haya mayor acceso a este tipo de tecnología, va a ser mucho más fácil acceder a la misma y probablemente nos beneficiemos todos.
En tu práctica habitual, ¿considerarías en algún paciente con algún tipo de sarcoma inmunoterapia?
Me parece que minimizó un poco mi primera pregunta Javier Broto, donde la respuesta que hemos visto en nivo más IPI más radioterapia o nivo más radioterapia en neoadjuvancia mostró un porcentaje de licuefacción o de quistificación de la lesión de casi del 80 y pico %. Me parece básicamente los sarcomas pleomórficos. Me parece, y también minimizaron tu pregunta, Fede, acerca del TMB, que me parece que tanto TMB como PDL1 en sarcomas no clasificables o sarcomas pleomórficos son los sarcomas cariotípicamente más complejos y me parece que son los más sensibles a la inmunoterapia. Y volvemos a la charla y la discusión que tuvimos hace una semana también con los mismos espectadores, no del curso superior, sí, también, que acerca del cáncer riñón. En cáncer riñón, el carcinoma renal sarcomatoide, que no es parecido a un cáncer riñón, es parecido a un sarcoma pleomórfico. Entonces, el beneficio que tenemos en los sarcomas pleomórficos o en o los carcinomas sarcomatoides de riñón es altísimo con la inmunoterapia. Mostró Janis Blay también unos datos de axitinib y pembrolizumab, la misma combinación que se emplean en los sarcomatoides de riñón. O sea que me parece que ese es el grupo de pacientes con el cual uno va a poder tener muchas más opciones que hoy. No es que no la ven, me parece que como es 1/3 de la población con sarcomas, es extender una indicación no muy arriesgada, sino muy costosa desde el punto de vista práctico. Pero me parece que ese es el futuro.
¿Alguna pregunta más que quiera hacer alguien?
Creo que estamos en tiempo.
Bueno, agradezco el tiempo de todos y nos veremos ya para el examen en agosto, ¿no? No, igual hay clases todavía por venir. La semana que viene están los sarcomas óseos y bueno, estamos entre la gente del Hospital Militar. Rodrigo va a dar la charla de tratamiento sistémico y generalidades. Estamos tratando de ver si también una de las oncólogas de mayor renombre en Italia también puede darles la charla de tratamiento sistémico. Me parece que más allá de aprovechar o no la charla de los expertos extranjeros es tener la posibilidad, y si quieren ármense preguntas, como si cada uno de ustedes fueran especialistas, básicamente a los residentes, no al resto de los especialistas que están ahí sentados, que ya tienen algunos años en la práctica, pero básicamente a los residentes armar preguntas destinadas, porque son básicamente próceres en la oncología mundial, así que no lo debemos desaprovechar. ¿Sí? Son algunas de las ventajas que nos da hacer esto fuera de cualquier norma de lo que las compañías farmacéuticas brindan. Esto es gratuito para los que nos dieron las charlas hoy y para ustedes también, así que hay que tratar de aprovecharlo.
Bárbaro. Con respecto al administrativo, antes de cortar, ¿alguien tiene alguna pregunta con respecto a examen o algún tipo de situación que quieran que resolvamos? Si no, también estimulamos para que si queda alguna pregunta de sarcomas también se haga. Cuando avisan la fecha del examen, damos una semana más para la inscripción y ahí distribuimos bien cuándo le toca a cada uno.
Sí, un mensaje para los chicos es básicamente que le transmitan a cada uno de sus jefes de servicio o staff del servicio la importancia del curso superior. Independientemente del vínculo entre ustedes, sino también la posibilidad de acceder a charlas que no van a poder acceder de otra manera, no por los argentinos que estamos acá y que siempre nos vamos a ver la cara en todos los congresos grandes, chicos o medianos, sino también el acceso a estas personas de referencia. Entonces, me parece que es muy importante la transmisión a cada uno de sus jefes de servicio para que puedan participar, no solamente ustedes, sino también ellos. Y es importante que estén concientizados del compromiso nuestro para con ustedes.
Carolina, ya empezamos a distribuir un link con alguna de las clases que ya estuvimos autorizados a subir. No sé si no te ha llegado, después te lo reenvío.
Bueno, chicos, la semana que viene es a las 5:30, volvemos al horario habitual. ¿Bien? Si llega a haber un cambio por algo, les avisamos, quédense tranquilos.
Bueno, muchas gracias Matías, muchas gracias a todos y por la excelente jornada que hemos tenido.
Bueno, gracias.
Chao, chicos.
Chao.
Chicos, quienes no hayan recibido las clases, por favor envíen a Curso Superior un mail diciendo que no las recibieron, así los ponemos en la lista de difusión.